Yeah. So, good evening, everyone, and my pleasant duty to welcome each and every one of you to this SPARSSH program today. And then today we are going to discuss very important topic, and that is on lung cancer. And the most important thing we realize is that we see almost 70, 80, and 90% of the patients of lung cancer in stage 3 and 4 across India, depending on the institute that you are in. And it's very important that we should have early diagnosis of the lung cancer to offer them a better cure than what we are able to do it today. And most of the patients are diagnosed as pulmonary tuberculosis in the first 6 months. And I think almost 60% of the patients are offered ATT in India, according to one of the studies which has been done in South India. So I think it's very important to diagnose the lung cancers very much earlier. And we have no other better person than Dr. Animesh Arya, who is a graduate from MAMC and postgraduate from RML and from Ram Manohar Lohia Hospital. He's got vast experience in the pulmonology, and then we'll be more than delighted to hear from him the approach to the lung mass. Over to you, Dr. Animesh.
Thank you very much, sir. And uh, I'll just share this. And is the screen sharing okay?
Yes, sir.
Yeah. So thank you, sir, Dr. Rangaram, and for giving me those words of praise and really raising the morale. And so also thank you, Dr. Sushant and Dr. Samit and the SPARSSH Foundation for having given me this opportunity to share my experience of approaching a patient with lung mass, and particularly in the journey towards diagnosing lung cancer early. And we all must be knowing that the lung cancer is the second commonest cancer in the world, and in the US at least, and maybe third commonest cancer in the world after the skin cancer and maybe other cancers. So it is unfortunate that we are not able to diagnose, as sir said, early enough in the course of illness. And that is why last 1 decade or maybe last 5 years have been so much instrumental in letting us to approach this particular disease is most fervor and zeal and very proactive measures so as to make our patients better. So the first slide is basically the introduction to lung masses and Fleischner Society of Thoracic Imaging, which is the best source of information in radiology, particularly the chest. Any pulmonary pleural metastatic lesion seen on chest radiographs as an opacity greater than 3 centimeters in diameter usually is called a lung mass. Lesser than 3 centimeters is usually a nodule. So there is a separate guideline defining nodule and how we work on a nodule, then a separate guideline how we define a lung mass. Why is it so? Because mass is more likely to be a malignant in 95% of time if there is certain characteristics associated with it, if you're able to rule out with a large degree of certainty that it is not a benign structure. And that comes with experience and a lot of radiology into it. So if you're a good pulmonologist, you have to be a better radiologist, because pulmonology is 100% radiology. Radiology is not 100% chest because there are so many things, but radiology 100% is with the chest, otherwise you're not able to do anything. So, but only problem is imaging alone cannot differentiate between various lung masses, and calcification in a lung mass does not exclude malignancy. So what used to believe when we were in college, that by checking on a simple X-ray, because we didn't have modality of CT, MRI or CT guided biopsy, ultrasound of the chest, EBUS, TBNA, or electromagnetic navigation. So we had to resort to the scratching of our head and looking at the X-ray without angles. But again, the calcification which used to believe that possibly you can exclude a malignancy, it no longer holds truth. And these are the clinical findings, the previous films, and the imaging evaluation. The same various characters which you see: location, number, size, change in size over a period of time, calcification, fat density, water density, air bronchogram, cavitation, nodule character, lung interface, contrast enhancement, bone destruction, all have to be taken in account. And if you see that the tumor doubling time which we normally see Less than 1 month usually suggests an infection, infarction, very aggressive lymphoma, or a fast-growing metastasis. 1 to 18 months falls, it's a huge length of time. Any time here, you could possibly be a malignancy. So that's why the most of the screening modalities in the chest, like multiple screening of X-rays in Australian trial, in the New Zealand trial, in the British trial, they failed because there was no trial which could predict what is the shortest duration of chest X-ray and then later CT scan, which could possibly detect a nodule well in time to be resected, to be clinically cured, and then also be a malignant. So it is very, very difficult. So a long period of time, anything could be malignancy. More than 18 months, such as granulomas, hematomas, carcinoid around atelectasis. So this is a type of calcification which we normally see. Nothing is so typical except for an eccentric calcification, which could still be malignancy. Popcorn calcification classically in sarcoid nodes, central calcification classically in granulomas, hematomas, various other forms are also there. So the Heinz-Fold units, what we see in CT, also has been shown somewhat correlating with CA, but not so much so. So if you remove from the earlier diagram which I showed, the size, change in size, calcification, character, nodule, and contrast enhancement, which are not to say classically we can say on malignancy or not malignant, we are left with this kind of a shorter characteristic of a mass on the chest X-ray or also on the CT. So location, number, water density, fat density, air bronchogram, cavitation, and if there is any adjacent wound destruction, which could lead us to shorten the list of what would stand for whether malignant or benign and what kind of malignancy. So remember that every radiological evaluation points, there are exceptions, and clinical data, previous films, correlation is essential to reschedule or reach the diagnosis. So exceptions are always there, and never be dogmatic about a certain finding on CT scan. That is a learning point both for radiologists and chest physician and for the oncologist. So we don't be kind of side laid with a presumption. This is what it is, and I've seen 100 cases and like that. Unless you prove with biopsy and a large chunk of biopsy, which gives you a definitive diagnosis, never comment, because one misspelled or directed wording in front of the patient may take a lot of toll, because patient will believe that it's still non-malignant. It comes malignancy, it shatters his dreams. So never open up if you're not too certain. So this is how a pleural-based mass would be, like extrapleural, pleural-based, or a nodule. So this is the definition and how well you'd approach by a biopsy, either an image-guided ultrasound or a CT-guided. And this is the lesion, what you see here on a chest X-ray, which is looks like a lesion on the parenchyma, but here it is possibly a pleural-based mass, and it needed a biopsy. Similarly, this is the parenchymal-based mass, probably lung cancer. So if there are multiple, likely to be metastatic carcinoma, less likely to be Wagner's or lung abscesses. And this is how it presents. These are multiple metastases. It's like a cannonball. So once the cannon is hit or once the shot is fired, it splits open into numerous sizes. So if you see a gunshot injury or a wound injury in a patient who's shot, you find multiple bullets or multiple pellets elsewhere. So similarly, it's like a cracker spreading across the lung. It's either a metastasis, Wagner's granulomatosis, or a septic emboli. So this is Wagner, this is septic emboli. So if it's solitary, it could be primary pulmonary carcinoma, which is most likely, as I said earlier, that 95% and above, if a characteristic of a lung mass more than 3 centimeters could be malignancy. Less common are metastasis, hematoma, sequestration, and AV malformation. So this is again a lung cancer. You see the obtruded bronchus sign. It's a solitary large lung tumor. And this is probably a lung abscess. And this is a extralobular sequestration. Very much look like a cancer, but only diagnosis can achieve by a biopsy, a large true cut biopsy, CT guided, and then a pulmonary and a aortic angiography, and then finally a surgery would be like the answer that it is a extralobular sequestration. water density, or what is the Hounsfield unit of the CT. A thin invisible wall is diagnostic of a cystic lesion. It could be hydrated cyst, bronchogenic cyst, or a fluid-filled bulla. So this is how an hydrated cyst would look like. This is a primary or a pulmonary bronchogenic cyst. And then comes fat density, minus 30 to minus 120. Fat density is lipoid pneumonia, metastatic liposarcoma. That is very, very important to differentiate. So don't be late that it is a fat density. It cannot be malignant. It could still be metastatic, liposarcoma. So this is what it is. This is how the fat lipoid pneumonia would look like. Air bronchogram sign on a CT scan, classically seen in a bronchoalveolar carcinoma, could also be seen in lymphoma around pneumonia. So this is classical, like a bronchoalveolar carcinoma, a large tumor peripherally located and usually producing volume of mucoid expectoration with eccentric air bronchograms. And this could be CA, could be lipoid pneumonia or lobar pneumonia. This is again, this is again a fat density pneumonia. Now, if a nodule has cavitation, an air kissing sign, what usually is, cancers cavitate less. They could develop in the surrounding wall of a long-standing unhealed cavity, particularly in a tubercular cavity. Then it would be like an eccentric growth with a typical thin rim above and a ill-defined fluid level, which is more or less not a fluid level. It is like a wavy sign, or it's a wavy sign inside a cavity. And it could be that limited value is addressed to cavitation in a mass, and it is more important is the morphology of the cavity. So if you see what is inside the cavity, what is the inner lining of the cavity, what is the outer lining of the cavity, and what is the thickness of the cavity in this cartoon, if you see, and how many numbers of cavities are there. So benign lesions are usually less than 4, malignants are more than 15, and nodular inner wall, and between them is equivocal. So this is classically a, could be lung abscess, could be malignancy. So contents are also important. If there is a fungal ball, it could be mycetoma, aspergilloma, or a ruptured echinococcus cyst. Or if there is a fat, smooth, air-filled level, it will be pus inside or a neoplasm. So this is classically an intracavity ball in an old cavity. So these are various morphologies. Meniscus sign, water lily sign, classically of hydrated. Meniscus sign is early rupture of an hydrated. Rising sun sign, Cumbo sign, serpent sign, spherical cyst. But these are usually limited to a very well taken chest X-ray rather than a CT scan, because usually the differentiation about 50 to 70 years hence was dependent purely on a chest PA and right or left lateral view or a decubitus view. So you had to be very sharp and clinically oriented and also nature oriented to distinguish various patterns and associate with them various pathologies. Now, if there is an adjacent bony destruction, it is almost pathognomic of a lung cancer. Very occasionally, a tubercular invasion or a tubercular osteomyelitis could be there, or a chondroma or chondrosarcoma would be there, or a metastatic bone cyst could be there, or could be hyperparathyroidism. But usually it is oncological primary malignancy adjacent or a metastatic disease. Now we'll run through in about 5 to 7 minutes. I'm left with a few of the cases. A 67-year-old woman, large mass. If you see the bronchus is obturated and it is lung cancer. Similarly, this is a peripheral mass with necrosis in between, but if you see but margins are pretty smooth and very easily approachable. You can do an ultrasound guided biopsy and get the result in less than 6 hours. And finally, within 2 to 7 days, immunohistocytochemistry can give you an answer how well to progress with the management protocol, lung cancer. This is classically a water density with a filled hydrated cyst. And this is basically mycetoma, aspergilloma. And So these were the various representative cases. And now we basically come to the second and the main part. How do we approach the diagnosis of lung masses? So basically, uh, what has changed in last 5 to 7 years is more and more availability of CT scan and very high resolution CT scans, giving us a very proper window when we approach a mass or a lesion on the CT scan for a image guided fine needle aspiration cytology. Then we also have bronchoscopic approaches, which are very, very prime, which are more for central lesions. And if the patient is not amenable to a CT guided FNAC, or the lesion is too distant from the periphery, where there is chances of pneumothorax bleeding, or the patient is unstable, he cannot possibly lie down for long, and a repeated punches could be dangerous. Then you have a simple bronchoscopy where you can find larger or central tumors. Then we have a very good adage, that is the linear and the radial probe ultrasound guided bronchoscopic biopsies, which have taken the whole, pulmonology, the lung oncology by storm. And we are able to diagnose to large accuracy, nearly 90 to 97% of cases with this modality. And of course, because the linear addresses to the central and the lymph nodes, we can do a staging. The radial probe addresses to the peripheral. And depending on this, we have also a new modality, which is virtual bronchoscopy and electromagnetic navigation, where we have a reconstructed CT image. It is put on a computer camera, and there is a like a joystick of the game or a video game. The joystick, you move the joystick on a virtual bronchoscopy and keep taking the joystick along the path of the bronchus into the area of the suspicion, and then that is memorized. So while you're doing a bronchoscopy and putting in guide wire or putting a biopsy needle, then that image guides the person that where you have to take the particular bronchoscopic forceps and reach the point of absolute, bull's eye, and then take the biopsy. So we are starting to have that new modality, but majority of us are having the linear and the radial probe, and of course the CT guided FNAC, which is very, very easily available now. So this is a 55-year-old male case, smoker, poor lung function, PET is intermediate. So what would we do? Observation, a radial EBUS, bronchoscopy with electromagnetic navigation, or a CT guided or a conventional bronchoscopy. So at the outset, it is very clear that CT and conventional bronchoscopy are out. You can try a bronchoscopy, but you may not be able to highlight or visualize the lesion. You have left with the option of radial EBUS or a bronchoscopy, because the PET is intermediate. You can't leave the patient as such. So basically, you do a radial EBUS and find that it is right in the center, and then it turns out to be malignancy. And you should also know what is not a predictor of malignancy: volume doubling time, nodule size, nodule location, enhancement. These are all very variable, as we said. And larger size and enhancement by dynamic CT also predict malignancy. Location has not been really shown to rely basically predicting of malignancy. So the structured approach to management of pulmonary nodules, if there is a very high probability of resecting a nodule which is staging is much low, either 1B or 2A, or very limited disease or not spread, as we call it nowadays in PET CT evaluation, then of course surgery offers the best cure. And mind you, about 30% of squamous cell carcinoma are central tumors, or even for that matter, few of the small cell carcinomas could still be resectable. And if they are resectable in toto, you have a confirmatory diagnosis and you are absolutely curing the patient, and the 5-year survival is very, very good. However, if there is an intermediate probability, what is the likelihood of cancer being there? And still you can do a surgery if it is amenable. If it's a low probability, then you just observe. And so if we were to see basically what is the most influential thing in predicting a successful biopsy? whether it's, of course, leaving aside the surgical biopsy. Radial, 18%. Air bronchogram sign, 47%. So if there is a air bronchogram sign, then you are quite sure that you're going to hit the lesion about 50% of time. 29% the lesion side, if it is larger than 3.5 to 4 centimeter, then it is likely. Or if it is distance from the pleura, then it is very, very difficult. It's very, intermediate. You can't possibly do anything, and you have to just rely probably on repeated testing. So this is how a radial ultrasound works. Radial EBUS work. We're going to acquire this by first week of April in our department. So this is when the radial ultrasound hits, the radial probe hits the lesion in the center. You look it like this and you see this, and you remove the ultrasound probe and keep taking biopsies. And this is where it is eccentric. Here the chances of yield is much less. Here it would be more than 50%. Here it would be just about 27% or so. So the lesion size, and less than 20 millimeter, it is 60%. More than 20 millimeters, it is 82%. So higher the size, quite natural, it is likely to be more or less, confirmatory for whatever pathology it has. So if you see the upper image, the lesion size is much less. Here it is more likely to give rise to better diagnosis than the upper image. So which following instruments have the highest diagnostic yield? Forceps, brush, needle, or bronchial washings? So you'll be surprised, bronchial washings have 0 yield. Needle and forceps have the highest yield, the brush has less yield. So it is always should be combined with a needle and a brush and a forceps. So here you can see that a study was done where EBUS was TB&A with combined forceps and brush biopsy. The difference is quite evident, and the combined yielded 78%, where the individual yielded very less. And the pneumothorax did not differ in both the groups. So this is another question: radial probe, electromagnetic navigation, virtual bronchoscopy, or seated guided aspiration, which is the highest yield. So we have discussed that if it is a periphery lesion, nothing better than a CT. And if it's a central lesion where CT would be a little difficult and can lead to complications if the patient is not well, a radial probe endobronchial ultrasound, if you have 5 to 6 biopsies, of course, the limitation is still patient could have pneumothorax and bleeding, very common, but the yield goes up to 78 to 84%. So this is how a CT guided yield is about 75 to 90%. Complication is 8 to 64%, very high rate. But if you select your patient, if you have all the preconditions well taken care of, you have a backup team, the complications are rare. And we are fortunate in Action Cancer Hospital. We have very good gentleman, Dr. Anurag Jain, who's been assisting us and our fellow people, Sumit and Sushant and other people around, in performing an excellent CT guided needle aspiration, true cut biopsies, and giving us the diagnosis right on the back. So it's very, very important to have a very good operator who is very confident and very, well versed with this technique. So this is virtual bronchoscopy and electromagnetic radiation. It is also now coming up, and it is 72% yield, which is very, very high. And so this is the radial probe, and it goes in, and it just localizes that lesion, and then you keep the sheath in place. You remove this probe, and you put the biopsy, somebody holding the sheath, and keep taking punches of biopsies repeatedly, and you get the diagnosis. This is how radial probe image of this particular thing sees. So this is where the thin radial probe is entering and is eccentric. So you probably withdraw it, try to still localize, in a center where the chances of yield are very high as 72%. So thank you everybody for giving me this time, and to share that we should not leave any stone unturned in suspicion of a malignancy in the lung, because as sir said initially, majority of the patient, maybe 2/3 of the patient or 3/4 of the small cell carcinoma patient have already metastasized by the time they are with us. And in the periphery, to an uninitiated person, they are still being treated as infections, particularly tuberculosis, or maybe not looked into at all. And we have very good modalities, very easily available, easily doable, and which gives a diagnosis in less than 48 hours, confirmation with IHC in about 5 to 7 days, and right on we can start the treatment. And we should all be very much aware of these diagnostic modalities, and which can be based used of in diagnosing lung cancer or lung mass. Thank you so much, sir.
Thank you very much, Dr. Animesh. I think that is a wonderful exposition of the entire problem of the early diagnosis of lung cancers, and also the getting the tissue for further workup in the lung cancer. So we'll be happy to have the questions from the audience, if any. And while that is going on, one of the practices which I've seen, it's not specific to any particular center or a particular doctor, but in general, a lot of people are put on ATT the moment they see it's at all levels it happens. After seeing the cough, hemoptysis, some weight loss, fever, and then straight away they go in for the ATT with AFB seen, not seen. Would we advise all the people to have a definitive diagnosis of pulmonary tuberculosis and rather not start the empirical ATT?
Yes, sir. So nowadays we have the CBNAT or the nucleic acid amplification test like Gene Expert, which can detect in a small zero point 0.1 ml about as little as 10 bacteria, and it's very specific for Mycobacterium tuberculosis. And the turnaround time is less than 6 hours. And in most of the big hospitals, all the district tuberculosis centers, they have the Gene Expert CBNAT test. And if a properly collected sample, even if there is a blood content, gives you an answer very early. And we also find that bronchial lavage, the bronchial aspirate fluid, the CT image or ultrasound image guided fluid aspiration, and so much so the mediastinal lymph node aspirations, if they are subjected to the CBNAT, we get a diagnosis in less than 6 hours. So nobody should shy away from responsibility of diagnosing TB correctly. If at 70 years of independence and so many programs which have passed our eyes, and still we cannot diagnose a TB, it's a real shame. So it behooves on us that we must diagnose first a TB correctly, and then only put him on ATT, or else at least work him up for something else.
Right. Thank you. And then there's another question from me again. This is about the obtaining sufficient tissue for the molecular test, the driver mutation, because nowadays the pressure is on too much. If
Yes.
they may like to have a tuberectomy to have the complete genetic analysis rather than a small piece, because the pathologist says, please send more tumor, please send tumor, as if it's like an apple, you can get it from there in that place. So if you have a peripheral node, of course, that makes the job easier. But when it's central mass, and when the tissue is being obtained by bronchoscopic things, sometimes then that too at the first time the tissue may not be adequate, and then that's where we got lost. So do you keep that in mind when you're doing the bronchoscopy and high index of suspicion is there that time?
Yes, sir. Thank you for highlighting that. And it is said that in bronchoscopy or lung pathology, tissue is really an issue. So with both the oncologists and the pathologists, because pathologists sends away the slide as inadequate or crushed, and we have to repeat the test. So nowadays, as we are aware, we do cell blocks, and the needle aspiration from a mass, the FNAC, or even our EBUS, that is the linear EBUS probes. And if we were to show that to you, we really get material from the nodes or from the masses, which is as jelly-like as a bone marrow. And it forms into a beautifully organized drop. We put it in a conical, blotting paper and put it right immediately into an alcohol. It fixes it and causes a cell block. So that is where it is really come to a rescue. And then if you are very sure there is no complication, we normally would take 6 to 7 passes to obtain that kind of a cell block, at least 3 of them. So at least one could be utilized for HB, and other 2 could be utilized for first a mutation and then the genetic consequence. So I know you're referring to whether it's people are not stopping short of TTK or ALK, they are going into CYP7 and whatnot and everything else. So you're better aware of that. So we are trying to get as much as tissue, but only thing comes in radial EBUS, because repeatedly disturbing the mass can lead to bleeding, which can be a little dangerous. And also, once you've done 2 passes or 3 passes, if the bleeding starts, the third and fourth is actually useless because you just get blood, nothing else. So you have to be very careful that you get, and it is not usually gives you a better yield. It is the correct site of biopsy without the blood tag in it that gives you a better yield.
Right. Right. Thank you very much. Any more questions? Anyone? Anything
Yeah,
from audience?
I have a question, sir.
Yeah, Professor Ullas Batra.
Sir, good afternoon. Hi, sir. How are you? So I had a comment about tuberculosis actually. Sir, I mean, in the last 2-3 months, we had patients who had a mycobacterium tuberculosis present in addition to malignancy. So, I mean, that is also something which is very important. And, I would stick my neck out and say twice I have burnt my fingers, toes, hands, feet, saying that, okay, तुम्हें tuberculosis है, आप घर जाइए. But one thing which I am now realized is I asked them, you take ATT, come back to me after 2 to 4 weeks. We'll do a repeat CT scan and then we'll see what. So that's just a suggestion that, just because you have a very low level or a low level detected on a gene expert, we should call them back. And that's, I hope that goes true for the respiratory physicians also. Dr. Arya, your comments.
Yes, Dr. Raj, you're right. Because first we cannot ignore a gene export, report, because it detects the genetic material and most of the sensitivity and specificity. The gene expert is actually the company's trade name, whereas it's called the CVNet. So we have now Gene Expert Ultra. So that Ultra is detecting even lower levels of mycobacterium DNA. So we cannot ignore that. And now the problem is coming, the machines have become so very specific or sensitive rather, they're detecting trace. Now the WHO says the trace has to be taken again with a pinch of salt, but if you have 2 traces, you have to treat as TB. So you're right. So there could be a coexisting disease, but and the patient maybe just as people, we have a chronic pulmonary tuberculosis where people are harboring bacteria for years together, and lo and behold, he has a malignancy over and above it. So if the characteristics we discussed in the CT finding, the eccentric wall and the eccentric mass with speculation, the tumor doubling, after the radiologists are a big help in that. So chest alone is not sufficient. Radiology is a big tool. And now we have with artificial intelligence, we have at least in idiopathic pulmonary fibrosis called a caliper, this thing. There are more than 10 lakh images of idiopathic pulmonary fibrosis, ILDs are fed in. And it gives you a diagnosis to the tune of 92% what kind of ILD is it. So similarly, if we have something in other places in place, particularly lung pathology, it could aid us in bringing the patient back, subjecting him to a second intervention, and diagnosing a lung malignancy.
Right. Thank you very much, Dr. Animesh. I think that's a wonderful discussion. So thank you, everyone. I think we'll proceed in the interest of time, we'll proceed for the next talk. And that is a very sophisticated talk by Professor Ullas Batra, that is beyond 2020. So we've already come to 2021. And then, so this is beyond the targeting EGFR exon 19 and L858R in the new era. And no other person than Dr. Ullas Batra can unravel the mystery here, how to treat such patients. Now we are so mutation specific. Over to Dr. Ullas.
Sir, good evening. It's a pleasure always, but I think, sir, in the last 1 week, we have interacted more than we have in the last 6 months. So I think you have got a newfound interest in lung cancer too, actually. That's very good for all our lung cancer patients, because if Dr. Rao has taken an interest, that means lung cancer will go much beyond.
Why?
And very few people actually, I hope people know that when sir was in RGCI, sir, you had the lung portfolio with you. Yeah. I still remember you were the one who introduced the Pemetrexed. You got the Lilly people to come in those breakfast classes. And the Pemetrexed story actually unveiled for me over there, actually. And always very fond of the way sir conducted the DNP classes at that time. And if I can be only 10% as good at what sir was, I think I would have a job well done. Oh, but that's besides the point. Coming to the main topic, My topic of today is Beyond 2020, targeting EGFR exon 19 and L858R in the new era. And let's start the journey of EGFR mutant non-small cell lung cancer in the 2 decades. So I'm starting from 2000. I am actually starting from 2004, 2005. EGFR mutant non-small cell lung cancer was like this beautiful girl who had only one suitor, and she was looking for some more suitors to come. I'm definitely not saying that she was married. It's probably a very unmarried girl who wanted some more kind of people to come around. And that was the journey of EGFR mutant non-small cell lung cancer from 2000s. And now in 2020, the young girl has blossomed into a very beautiful girl more. So this center girl is basically the EGFR mutant non-small cell lung cancer. You have one suitor which basically says you can have a sequential treatment, second followed by third. You can have another treatment which is EGFR chemo and TKIs. You can have only osimertinib, or you can have the TKIs and anti-angiogenic. So now the girl which had only one suitor in the form of first generation TKIs is now has got multiple choices. In fact, 6 choices right now to choose from. So let's start from the start, because we are so distracted by how the things are today that we usually forget how beautiful the beginning was. So I will take you to a journey of the old era, and then I will take you to the new era, what we are exactly seeing. So let's start with the evolution of TKIs, and this is how the TKI is evaluated, probably almost similar to the human species, faster, but definitely better. I don't think so. So let's look at the initial data of gefitinib. We are all so used to seeing the IPAS curves and beautiful curves. Please know the fact that when gefitinib and erlotinib were started in 2003, they had an overall response rate of 11%, 8%, 18%, 19%. And the progression-free survival was 2.7, 2.8, 1.9 versus 2 months, with a median survival of only 5 to 7 months. They were in fact called as the miracle pill over there at that time also. But please note the PFS and the overall response rate that they had. This was the trial of erlotinib. Please look at the median progression-free survival 2.2 versus 1.8 months, and a median OS of 6.7 versus 4.7. The HR is fantastic, 0.61 and 0.070, but that is because your denominators was atrocious. That is what exactly this was. Please try to remember both gefitinib and erlotinib, they were not designed to target EGFR mutation. They were designed, and by mistake, what we found out in the real target when you have a EGFR mutation, when the IPAS study was done by Tony Mock et al., this was in an EGFR unselected population. For all the medical oncology residents who are listening, the IPAS trial, the Tony Mock trial, was not done in a EGFR selected population. They compared gefitinib versus paclitaxel, then found out that the people who are EGFR mutant actually did better with gefitinib than people who were negative. So there was no overall survival advantage still in the first and second generation TKI. So that led from first generation to second generation TKIs. Now please note that why was the second generation TKI developed? The second generation TKI were developed because of their increased potency. So first generation EGFR TKIs, they were just randomly, they were just found out that they were active against them. Second generation were designed to have increased potency. They were the irreversible because they wanted to have an irreversible bond. They were pan-HER blockers, and they formed an irreversible bond with the target. And those were the differences that were there between the first generation and second generation TKI. So more potent, irreversible bond, and they were a pan-HER inhibition. So please try to realize what were you trying to achieve when you found out the dacometinib. So as also you can see that potency as determined the IC150. If you look at exon 19 and you look at the dacometinib, the potency, just look at the IC50s of dacometinib, 1776. Look at the osimertinib IC50. For dacometinib it is 76. For osimertinib it is 340. For L858R it is 531 versus 40. So there was an increased potency of the drug of dacomatinib against the second generation drugs were basically more potent actually. Now, this was the early phase trial data, single arm phase 2 study of Archer, where a response rate was 76.8% with dacomatinib. Again, this was the single arm study in which the median PFS was 18.2 and the median OS was 40.2. And please note the subscript in the right footnote. This was in 2014, where dacomatinib in a single early phase 2 study had a median OS of 40.2 months. Now with this, dacomatinib, I think I have lost some of my animations. Dacomatinib was basically compared with gefitinib, and what we can actually found out over there is that the overall survival was with dacomatinib was numerically significant. It was not statistically significant because of a hierarchical study design. But if you look at it over here, the OS is in the tune of 34.1 versus 27.2. 27.0, and OS at 42, the one in the red actually, and how many people are alive at 42 months is 41 months with dacomatinib versus 33.6 with gefitinib. Dacomatinib is definitely a toxic drug. There is no doubt about it. You start the people at 45 mg, 66% of people had a dose reduction to around 30 mg at their lowest dose. So definitely the drug is toxic at 45 mg, not at 30 mg. But let's look at this, that whether the dose reduction of dacomatinib leads to a meaningful deterioration in overall survival. And these curves actually see the curve on the top is basically when you take dacomatinib for 15 mg. The one in the middle is if you take it at 30 mg, and the last one is if you take it at 45 mg. Not to say that 15 mg is more better than 30 mg is more better than 45 mg. It basically says that people who took 45 mg reduced to 30 mg are the ones probably who took it for a longer time. So in my clinical practice, and I have spoken to lots of people, including Daniel Tan, Tony Mock, everyone starts dacomatinib at a dose of 30 milligrams and then only decreases or increases the drug dose, because 30 mg is absolutely efficacious without any having its side effects. So dose reduction, we don't know, who cares, doesn't make a difference. Now, this is very, very important. The results in Asian versus non-Asian. This is the dacomatinib study, the Archer study. In both Asian and non-Asian, dacomatinib, the diamond is towards the dacomatinib study. But you look at, you go to the, when I speak about the AZ, they asked me to show the other graphs. And when I spoke about the Pfizer, they asked me to show the other graphs. But if you look at this in the Flora study, look at the one with the Asian, the diamond is exactly at the unity, and this did not actually benefit the patient with the Asian subgroup. So third generation, and then came the third generation. Now please again understand, first generation unselected, second generation increased potency. Why was the third generation developed? The third generation was developed not as a more potent drug, it was basically developed to target the T790M. And again, you should look over here. So, it's very important to know why a drug was developed. Again, read the lines over there. The drug osimertinib is 30 to 100 times more potent against T790M. That is why it works in people with T790M mutation. It is 100 times less potent than the EGFR wild type, and that is why it gets no or very less side effects. So that's very, very important actually for us. And this was the osimertinib in the EGFR mutant non-small cell lung cancer. It works both in T790M and the Flora OS. Please remember the 38.6 month survival. So this was till 2020. So we saw first generation was around 11 months PFS, second generation 14.5, third generation 19.2 months. This is what we know of the old era. Now let's see what we have to do beyond 2020. And this is the book that we should obviously read. That is by APJ Abdul Kalam about Beyond 2020. It's a fantastic read and it's a must read as far as I'm concerned. So let's have a look at how will we treat the EGFR mutant non-small cell lung cancer in 2025. Now that brings me to the core of my topic, that are the deletion 19 and L858R mutations created equal? I don't think Dr. Rangarao will remember these two guys, but I'm sure Samit will recognize this guy, And these guys are Hrithik Roshan and Harman Joshi, and they look almost alike in 2008. But today, Hrithik Roshan looks like this, Harman Joshi looks like this. So whether the same is going to be the story of EGFR mutation DEL19 versus L858R in 2025. Let's look at this. Let's look at the preclinical data. Let's look at the clinical data. So let's look at the preclinical data. For everyone who is struggling to get a hold of what I'm saying, please look at my next 10 slides very, very carefully. Now, L858R has a higher incidence of concomitant mutations. We in India are not still doing NGS routinely. People in China, Hong Kong, Singapore, Taiwan are doing NGS regularly. So if you do NGS regularly, what they are finding out is L858R has a higher incidence of concomitant mutation. And this was a study that shows 69% of L858R had a concomitant mutations. This was again a study which basically said that people with L858R had more de novo T790M, they had more TP53, and they had more other mutations in the L858R subgroup. And if you have, this is again one thing which is basically showing the incidence of compound mutation in L858R was 19.5 and in DEL19 was only 4.7. Also, secondly, if you have a DEL19, you have a higher chance of getting a T790M. So DEL19, less incidence of co-mutations, more incidence of T790M mutations and progression, where people are more likely to take the osimertinib drug. That is why maybe osimertinib or anybody with a DEL19 will do much better in survival as compared to what somebody with L858R. Now, L858R often coexists with co-mutations. And remember what I told you about dacomatinib, second generation. Dacomatinib is a pan-HER inhibitor. So even if you have a co-mutation, dacomatinib is that drug which will probably going to work more against them. And that is why the presumption that dacomatinib will act better in patients who have got a L858R mutations. So this was the preclinical data I spoke about. Higher incidence of co-mutations, higher incidence of compound mutations, higher incidence of T790M in DEL19. Now let's look at the clinical data. Now let's look at the first generation TKIs in patients with exon 19 deletion. And we can always say that maybe they have a PFS of around 11 months with no benefit in OS with the first generation TKI. So let's look at DEL19 separately. With first generation, they have a PFS of around 11 months. Let's look at the second generation. Let's say dacomatinib in DEL19. It has got a median PFS of 16.5 months. Average was 14 months. It has got 16.5 months, dacomatinib. And even osimertinib has got a PFS of 21.4 versus 11 months. So whether you give a first generation, second generation, third generation, the PFS of our TKI drug is definitely higher in the DEL19 subgroup. Reason? Maybe a lack of compound mutations in the DEL19 subgroup. So let's see what happens. This is what we are showing. Osimertinib 21.4 months, 13.8 months with afatinib, 11 months with erlotinib. Now let us see what happens with exon 19 deletions. Please have a look at this graph. 21.4 months with osimertinib goes down to 14.4 months. 13.8 months with afatinib goes down to 10.8 months. 11 months with erlotinib goes down to less than 8.4 months. So a single agent TKI probably is not, first and third generation drugs are not very efficacious for an L858R mutations. But let's look at dacomatinib. For dacomatinib, remember I told you median was 14.8, L858R is 14.7, and the DEL19 was marginally ahead at 16. Again, the OS advantage with dacomatinib was maintained whether you have a DEL19 or an L858R. And this is again what the FLORA trial showed in L858R, HR of with Asian and an L858R with the HR of 1 in these two populations. So we have always spoken about the Western data. Now I'm going to show you the RGCI data. We had 1,530 non-small cell lung cancer patients, and after which we broke down our incidence of EGFR mutation was 36.2%. And finally, we have taken around 276 patients. Now let's look at our own data. The median overall PFS with all the drugs was 15.1. Median PFS with DEL-19 was 18.3. Median PFS with L858R was 10.1 with a p-value of highly significant. So it's not only in the West, this is also in the Indian our literature. And this was the overall survival advantage. Our own survival data with all the TKIs, the difference of allotted was 23.07 months. Median OS with DEL-19 was 25. Median OS with L858R was 17.8 months with a p-value which is highly significant. So I thought of this as a project initially for when I looked at the Western literature, but our own data actually supports this very well. Now let's look at my last slide. This is the Chinese data which I have taken from the CTON group. Now on the left, I have written about PFS advantage. So there are 4 drugs which have a PFS advantage as in the L858R subgroup. You have dacometinib, you have osimertinib, you have anti-angiogenic plus TKI, you have TKI plus chemotherapy. These 4 have got PFS advantage, but when I put this on the right, only one drug, that is dacometinib, has an OS advantage in the L858R subgroup. No FLORA, no Relay, no NEJ0009 has an advantage of TKI of OS as compared when we are considering about L858R, and that is why the CTON group actually has said that if you have a L858R mutation, they are considering dacometinib as the first line of choice and not osimertinib. Osimertinib actually comes into the medium one. So my summary, based on the molecular and clinical data, EGFR 19 deletion and EGFR 25 mutation could be considered as 2 distinctive types of EGFR mutation. Different TKIs have different roles for them, and in my opinion, I am bringing it to a fact that treatment strategies for both EGFR 1921, they should be benchmarked on comprehensive analysis based on efficacy, safety, quality of life, and that for me is Vision 2025. Because way back in 2025 or 2030, I want to have a lung cancer survival program in which patients should be more than a breast cancer survival program. With this, thank you, and I hand it back to Dr. Rangala. Thank you.
Yeah, thank you very much. I wish everyone has an opportunity to clap. I think that's a wonderful lecture. I think Ullas, I've been listening to you many times, and this was absolutely masterly, professorial, very good, and excellent. Very good. Very good. I think this particular data I've never seen so much in details, but I think I enjoyed learning a lot from you. Thank you very much, Ullas. So open to your questions. So dacometinib has just come in, right? I mean, it has just come in, approved about 6-7 months ago.
So dacometinib was always there.
It was always
there. It has only got the Indian approval. Pfizer is only, we had people in the compassionate access. It's an old drug which has been used. The data came, I think ASCO data came in 2017, Tony Mock, and then 2018, the OS data came. So it has always been there. Then it was there for compassionate usage. But now that the L858R and this comparison group is now coming up now in the last year or so.
Right. And then since you've used all the molecules, and how is the toxicity of this molecule as compared to osimertinib, gefitinib? We have of course used it and everyone says, as compared to osimertinib and this.
Sir, I think the toxicity wise, I don't start them at 45. Right. I start them only at 30. Right. I do not give it to people who are elderly. I give it to people only who are young. Again, my thing will be less than 50, 55, 60. I do give it over there. We were phase for clinical trial going up. I think we had 9 patients till now. None of them has progressed till now. Everybody has shown a great response. But something which we should remember is in the registration trial of Archer, brain mets were not allowed in that trial to start with. So I do not give them to people who have got symptomatic brain mets. Although in the phase 4 trial that we have, asymptomatic brain mets are actually allowed. Right. So toxicity is reasonable, sir. It's not osimertinib. It's not osimertinib. Osimertinib is fantastic drug, but it's a decent drug. There is a place for that. That's what I would say.
Yeah. So then we have the Lux Lung trial with the afatinib. Now, where do you place that? in the L858, because that is also another molecule which is effective against this particular mutation. And then I'm not sure whether you've shown the comparative data with the Lux-Lung and
I
this.
didn't actually, sir. So what happened was when afatinib was compared against chemotherapy, when afatinib was compared against chemotherapy in Lux-Lung 3 and Lux-Lung 6, they showed that the DEL19 subgroup afatinib was better, no doubt. But when in Lux-Lung 7 they compared afatinib to gefitinib, this data fell front on its face. So in that Lux-Lung 7 trial was a disaster for BI actually, and that is why the entire thing fizzled out. But when dacometinib was compared against gefitinib, not only did they have a PFS advantage, they had an OS advantage too. Again, the OS advantage was not statistically significant because of the hierarchical designs that has been used. The same design which have been used in the atezolizumab plus nab-paclitaxel arm, because the response rate were not significant, so they did not go on to that. But the data is good. I mean, there is a very wide variety. So normally how I think there are some questions in the chat box which are asking us how do we do this. I would say how many people of ours are able to afford the original osimertinib. I don't think in a cash paying this thing more than 2% of people will be able to afford. If you have a young patient, so then what is the option if you are not able to use osimertinib? You have either first generation, you have second generation, you have EGFR plus plus chemotherapy, you have EGFR plus anti-angiogenics. I mean, having used pemetrexed for a long time, now we are beginning to see the renal side effects of that. Now, there are people who have got a creatinine raise of around 2.2, 2.3, 2.4, and people don't want chemotherapy. I mean, let's be very honest about it. The moment you say it's an oral pill, chemotherapy, people don't take it. I mean, again, I did an analysis, sir, in the COVID era. In fact, we wrote more TKIs than we wrote chemotherapies in the COVID era. Because the moment you say COVID, the chemo, they will go off. So the moment you say chemo, people go off. So I don't want to give chemotherapy. So that leaves only second generation TKIs or EGFR TKIs plus ramucirumab. Now in ramucirumab, again, the PFS data is excellent. I'm sure Vikas Talreja will show that data, but the OS advantage has not been seen at present. So I think there is a place for this, and there's L858 group. And initially I thought we are only torturing the data and all, but then this is the data which I just got yesterday from my own 560 patients. I think there is some merit in the data. We need to work out more. It's a vision. I am not saying I'm going to change my practice, but I will not be averse to using dacometinib at all followed by sequential strategies in L858R. And I mean, this data I'm going to put in public domain. See, in our retrospective data in the last 5 years, I've shown you that DEL19s are doing better than this. Yes, there is no randomized control data. It will come up, but it's a good worthwhile approach to think of. That's what I can say.
Thank you. Wonderful. Very, very educated. Very, very good. And I'm sure there'll be more questions. And then, so shall we proceed? Thank you, Ullas.
There is a question in the chat box, sir.
Right. So I think the chat box Ullas has seen, and whether they still generated they're still being generated.
It's the same.
Yeah.
It's the same, sir.
Right.
Thank you.
On Tuesday morning, I will work tomorrow, Rajat. Rajat is asking on Tuesday morning. So Rajat, I'll ask you to come there on Monday and play Holi with you there.
Right. So Ullas is running a Holi OPD also.
Anything for a TKI, sir. Anything for a EGFR mutant.
Happy Holi to you, sir, in advance.
Yeah, thank you.
Rajat, you are welcome to play Holi in Unit 5. You know how nice we play Holi there.
I do know, sir. Yes.
Thank you. So with the permission of everyone, I think we'll proceed to the next one. I invite Dr. Mohit Agarwal as a for the panel discussion for next, I think, half an hour. May I request him to join in and then also invite the panelists?
Dr. Mohit would not be able to join, and Dr. Ullas Batra has been kind enough to take over as a moderator.
Great. It's always good to listen to Ullas, and then over to you, Ullas. And I think you should replace that Asian pictures with the Indian right in the beginning. You should only the Asian pictures. Like the ones you showed the Indian pictures later, I think they were good, more attractive than the Asian pictures.
I'll tell you this. I'll tell you the story behind it. This presentation I had used in the ESMO Asia.
Right.
So
Okay.
I had to put a picture over there.
Okay.
After that, I was searching for an Indian picture. Then my wife came and looked at the laptop. Said, "What the hell are you doing?" I thought you were making slides.
Right.
Now, sir.
Okay. So
Okay.
kindly
I think
invite
so.
the panelists and then.
Yeah, sir. Can you please invite the panelists? In the meantime, I'll just put on my slides, sir.
Okay, fine. So the panelists are the same, Sushant? So
Yes,
Dr.
sir.
Rajat
Yes,
Bajaj, I saw him. I think he's there. Dr. Rajat Saha, Dr. Rachit Channa, and then Dr. A.P. Dubey. So all four of you, please join in there and then say hello to everyone so that we know that you're there. So Rajat
Okay.
is there and
Yes, sir, I'm there.
yeah, I could see you there. And then what about Rajat Saha?
Yes, sir.
Dr. Shyam Agarwal is also there.
We could see Rajat Channa is there. Shyam Agarwal, he's always an expert standing behind and then ready to answer any question anytime.
Sir, good afternoon. Dr. Shyam, good evening, sir.
Yeah, I'm there, boss. I'm there. Don't
हाँ
worry.
सर आप
Good
यहीं
evening.
रहिएगा जाइएगा मत सर.
Yeah.
शाम का ही औरत है मैं हूं ना क्या प्रॉब्लम है
This is the third consecutive day. Sushant knows that.
Yeah,
सर 3 दिन से आ रहे हो. Not bad, sir. that is some dedication, sir. Okay. So I think I am going to. Can you see my screen?
yes, you're seen and audible both. Everything is fine.
Okay. So for the next 30 minutes, this is also something which I've done before. Actually, I would ask the talking to about the real world conundrum in treating an EGFR mutant non-small cell lung cancer. We have a case in which the 60-year-old female who has a history of cough and breathlessness, PET scan showed some nodules and right lung mass. So basically a stage 4 disease. I can start with Rajat initially. Rajat, what are biomarkers? Let's just start. And more importantly, third question, do you wait for the biomarkers or do you start chemotherapy? So your algorithm, Rajat, Bajaj.
So, sir, if it is a adenocarcinoma stage 4, then I'd like to send EGFR, ALK, ROS1, CMET, and BRAF. This is what I normally do. This
No,
can
come
be in
again,
the
Rajat.
form of,
Rajat, come again. What all?
sir, EGFR, ALK. Hello, am I
Yeah,
audible?
yeah, you are. EGFR,
EGFR, ALK, ROS1, CMET, and BRAF. And
Okay.
this is what I normally do. If it can be sent as an NGS, there are certain companies which are doing an NGS, and the TAT is around 10 days. Then I'm happy with that NGS platform, and these are the 5 that I would like to send upfront.
Okay. And do you wait or do you start chemotherapy? Let's have keep a hand on your heart, and we can see by the smile that what you do.
Yes. So this has been the conventional teaching that if the patient is not having much of symptoms and is asymptomatic, then we can wait. But if the patient is symptomatic, then I usually do start.
Okay, fair enough. What Dr. Shyam, you have a point? No.
Yeah, I have a very, very important point.
So you always have. Please, sir.
Yeah, you see, what is happening is that we are sending 5 tests and we have drugs for 10, right? So you get 5 negative and you start them on chemotherapy and immunotherapy. 3 months down the line, the drugs fail. And then you say, okay, now you do your, 400 gene panel to look at HER2, etc., etc. And number one, no, hold on, let me finish. And then one of those comes positive. So where are we? Where are we physicians? Where are we medical oncologists? So the patient says, why did you not order all this stuff in the beginning itself? And you have, made me spend several lakhs, and I would have taken the targeted drug right away. I would not have taken this silly chemo and immunotherapy. So, this has been bothering me for the last 1 week or 15 days. So I don't know, Ullas, you see, a huge number of such cases, and it's not far away that one patient will turn around and, is really going to put us into soup.
So
can I answer that?
No, yeah, Rajat, you answer it, and sir, I'll answer it in the end. Rajat, yes, and then Rajat Saha after that.
So, sir, like I said that because the turnaround time also is equally important, and that is the reason that this 5-gene panel for NGS is something that I prefer. But then if this comes out to be negative, and it is well known that there are other genes also that can be positive, so I make it a point to tell the patient that there are other genes also which should be tested, and there is another NGS panel for that. So simultaneously that can be sent, and the chemotherapy can be started. The turnaround time for that particular panel is say about 3 weeks or so, and by that time when we get that result as well, we can tell the patient as to what exactly can be done from there on.
Okay, so Rajat says NGS small panel, NGS big panel. Okay, NGS small panel, chemotherapy, then
Just,
NGS big panel. That's what
just
Rajat
because
is
of the
saying.
turnaround time is
Okay.
conducive for that.
Okay, Dr. Sham, your rebuttal on that, sir? Is that okay?
No, first you rebut and then I'll come in. I've raised a question. You want to answer?
I will answer it. I will answer
Yeah,
it.
I know. So no, don't answer this. This query of mine. Yeah, please.
Okay,
Yeah.
Rajat Chanana, Dr. Rajat.
Hello, sir. Good evening. So what I used to do is that I ordered EGFR, ALK, and ROS and PDL1. So, but now I am shifting to getting NGS done upfront if I think that the patient can afford all the possible targeted therapy.
So, Dr. Rajat, you have to tell me how many people will really be able to afford in the, let's keep a hand on your heart now. In the last 1 month, let's say you have seen 100 lung cancer patients. How many have you asked for an NGS?
So now I'm asking almost everyone for NGS.
No, you can ask. How many have done? You can
Most
ask.
of them. So I just only order comprehensive lung panel, which includes MET, RET, HER2, BRAF, EGFR, ALK, ROS1. So they can. Yeah, so I don't offer the 150. I offered only the comprehensive lung only. Most of the patients they do, and it comes out cheaper because the commission.
How much is the cost, Dr. Chandan Rajat? How much is the cost?
It's around 25 to 30. So the commission is saved. The hospital, if I ask the hospital, they'll send it to outside lab and they'll take the commission. So I tell the patient to give the sample directly to lab. So it saves the commission and it comes cheaper to the patient.
Which
So
lab?
I think
Which lab is this, please?
Which lab is that, Dr. Rajat?
Core and Onquest.
Core and Onquest are not doing, to the best of my knowledge, the 10 gene panel. Dr. Sham, we have our own lab, so I don't. Dr. Sham, are they doing?
I'm not aware. I am only aware of the Positive Biosciences, who I think recently came in and said that they can do these 10 genes now in about 20,000 with 3 weeks or maybe even less turnaround time. But I haven't, switched on to that. I think it is. So my query remains. It is not.
So I'll tell you, sir, my query. I'll tell you what I will do, sir. So what we are doing in Rajiv Gandhi now is, we have got, from next month, hopefully from April 15th onwards, we are moving to a 50 gene NGS panel. So what I am going to do is, we are stopping the single gene the testing. We will do I will do an ALK by IHC. That report will come in 2 days time. I will do an NGS panel and I will do a liquid biopsy for EGFR. The entire panel will cost us 28,000 rupees. That entire report, because we have our sensitivity, concordance rate of COBAS EGFR liquid is 98%. ALK by IHC I'll get in 2 days time. The NGS panel I'll get in 7 days time. If EGFR ALK comes as negative, I will start the patient on chemotherapy. That's what I am doing.
No. Hold on.
Hello, bolo.
Rajat, you have to mute yourself.
So, Rajiv Gandhi is smart, working on the lines which I am suggesting. So I think a broad message to everybody is either you document that you have discussed about this 10 genes and the family is not willing to do those 10 genes, because subsequently if you get one of those 5 genes which you have not done positive, then the patient always comes back and tells you, sir, why did you not do everything in the one go and you did all this, whatever I said before. So I think it is time that either we start documenting that the patient is not willing for that 10 gene panel and only wants to do 5 gene panel, and therefore you're not doing the rest 5. So the onus has to be with the family and the patient, not on the doctor. So that is the message I'm trying to convey very loud and clear to anybody and everybody who's listening to this program.
And the second message with Sushant, 1 second. I know you are the host, but I'll just give you one more point. And my earnest sir's message is loud and clear. And my earnest request is, even if you have a PDL1 of 90%, please do not start a single agent immunotherapy if you have not done a broad-based NGS panel. You will have egg on your face because of two reasons. One,
Absolutely.
your drug won't work. Second, if you have given pembrolizumab first, the drug half-life is 6 weeks. And then you give a TKI after that, you will bloody land up in a drug-induced pneumonitis and you will have double egg on your face. So this has happened to one of the oncologists in Delhi. I only know how I had to go to great lengths to pacify the attendants. So please do not start single agent pembro or either a chemoimmunotherapy, because if you want to give a TKI later on, the half-life you would have to stop for 6 to 8 weeks. That's the message I want to give loud and clear. Exactly what Dr. Shyam Agarwal said. Sushant, your point now.
Keeping my hand on the heart, I like to say that Novartis is providing us the NGS panel in the form of EGFR, ALK, ROS1, BRAF, CMET, and then this is for 12,500, and then extra 2,500 for PDL1. So that's what we are trying to convince to the patient, and about 80 to 90% are able to get that done.
No, Sushant, but the other one, Entrek hai and the HER2 hai and everything hai, we should, because if you have a, let's say if you have a, let's say you do a broad-based NGS, you don't do some, Dr. Shyam Agarwal will do, and you will give a single agent immunotherapy. That's the issue. And it's not only somebody else will do, the point is we are not doing justice to the patient. That's what I would say. Rajat Saha, you have been very quiet. Max normally is not known to be quiet.
No. I had some connection issues and I've just joined.
I
was
know
there.
you had some connection. I very well know you had some connection issues with us at RGCI, Rajat. Go on.
No. I was Asa. No pun intended.
All pun intended.
No, all pun intended.
Okay, tell me. What is your practice and what do you do? So
I actually missed that part of the conversation while I was trying to join in.
Okay, it doesn't make a difference. Let's just start. So what do you think, Rajat, do you want to wish NGS testing upfront for in your clinics?
Yes, we should do NGS upfront, even though hand on my heart, I still haven't started using it so frequently, but yes, we should do NGS upfront.
Okay, and one more reason which we should do NGS is because of the data that I showed, between L858R and DEL-19. We are doing a retrospective project. I think I told in the last panel also. We are doing a retrospective study of all our EGFR mutation presence of last 400 patients, trying to see what is the incidence of co-mutation. The data which I had shown about L858R not doing very well actually almost shows me that there's something wrong with L8. There's something more to it. I'm getting more and more into that concept. So give me 6 more months. I'll come back to you with the data. What about liquid biopsy? Doctor, let's say Denny just joined. Denny, you're still there? Okay. Rajat, what about liquid biopsy? Do you routinely use liquid biopsies? A for NGS, B for just for the EGFR mutations?
No, I have not used NG. I only use liquid biopsy if and when there is the biopsy is not feasible. That's only in one case I've used till now, but that also has turned out to be negative. And liquid biopsy I reserve only for progression after the first line or second line EGFR TKS to actually detect the T790, not as an upfront.
What about Rajat Bajaj?
Hello.
Yeah, Rajat, you're audible.
So I would like to use liquid biopsy, as Dr. Saha said, that if there is a progression, to look for T790M mutation. Otherwise, upfront, I'm not using, sir.
Okay. Rajat?
Same answer, sir. We don't use it upfront. We use at the time of progression only if you are not able to do a biopsy.
Okay. In fact, I mean, we again at RGCI are using liquid biopsies for EGFR detection by COBAS. Our concordance rates are 99%. There are people in which I can get a result tomorrow. I mean, so we do the runs on 2 days in a week. If we have good samples, so initially we started a research project, but our concordance rate of COBAS is actually 97, 98%. Sensitivity is approximately 98%. So that's a huge advantage that we have if we do a EGFR detection by a liquid biopsy actually. I think we will go. Okay, Dr. Sham sir, what is your opinion about liquid biopsy NGS?
So there are two ways this liquid biopsy can be done, as you've said, NGS and ddPCR. So if you have a lady adenocarcinoma, non-smoker, and you don't have tissue, you're very hard pressed, So I would, certainly go for a liquid biopsy, something like a ddPCR, which is dedicated towards EGFR. We have done like 50 gene panel, which is available at liquid biopsy, but somehow, the faith or the validation for the NGS, although the companies are claiming it is there, but then only I'll do it if I'm hard pressed. That will be my take.
Okay, Dr. Rangarao, so you're there?
Sir has left.
Okay, fair enough. So this is what the IACLC guidelines actually say. And let's move on to the case. You have a EGFR del19 present and PDL1 22C3. I think we all spoke about. Please do not give a single agent pembrolizumab to this patient between a EGFR and a IO. EGFR definitely takes the cake. This is what I showed you before. Okay, now let this question come to Rajat Bajaj first. Now, Rajat, do you think that the treatment of EGFR mutant non-small cell lung cancer with the first generation TKI in 2021 is suboptimal? If I give a gefitinib to a person and the patient goes to you for a second opinion, with your posh, OPD and all, do you think I am not on a good job?
Sir, I would send the patient back to RGCI. That is for sure.
That's okay. But tell me what would you take?
But the other thing, sir, is that after your talk, definitely I would say that yes, it is suboptimal. With the coming in of second generation and third generation TKIs, we probably are discussing about a patient who does not have financial issues.
No.
If that is kept aside, I certainly would like to discuss third generation TKIs with the patient.
Okay,
who is EGFR
let
mutant.
me rephrase the questions. In the last 100 patients that you have given TKIs to Rajat Bajaj, what is your percentage? Let's say, is it how many of them have been first generation, second generation, osimertinib, combination? Just give me a breakup.
So, sir, I think 2 to 4% would be osimertinib.
Okay.
About 70 to 75 will be first generation, and rest will be second generation, and that too afatinib, no dacometinib till now.
Okay. Why no dacometinib, Rajat? I mean, just since the Pfizer symposium, Pfizer would want to know that why no dacometinib? They will still give you dinner, what they promised after the COVID is over.
Yes, sir. So now I think the data is maturing more. My issue with dacometinib, I've told Pfizer people many times, has been the proposed toxicities in Archer study. But like I was understanding from your talk also, that it is probably wise to start with a reduced dose and then take it from there. So probably in times to come, and that too with L858R data coming in strongly, there'll be more and more people now switching to dacometinib as well.
Okay, Rajat, do you think Mahendra Singh Dhoni has become old and Chennai should replace him in the IPL? 2007, he was a World Cup champion, and now you think his days are over?
Ullas, sir.
Yeah, Sushant.
Sir, we have next session also, sir.
Sure. How much time?
So we are already 10 minutes late, sir.
Okay, I'm so sorry. So, okay, fine.
No, sir. Okay.
Give me two more minutes. Give me two more minutes, basically. So let's just value the pros and cons of, let's just go to and discuss dacometinib right now. I'll go to Rajat for the pros of dacometinib, and I'll come to Dr. Shyam Agarwal for the cons of dacometinib.
So the pros of dacometinib is, yes, it is now available, and we know that we can dose titrate without much loss of efficacy. So we can start with a 30 mg dose, and we have got good confident data supporting that. That's the pros. Secondly, again, emerging data that in the difficult to treat L858R, it is definitely more efficacious as compared to the competitor second generation and also the third generation. So that's a very big pro, which should leverage us to use more dacometinib in the near future. So these are the two things.
Okay, Rajat.
Sir, the pros are that the drug is available and the cost is relatively less as compared to osimertinib. And the con is the skin toxicity. I have given to one patient on compassionate basis. He's tolerating 30 milligram very well. And another con is that we don't know what's the mechanism of resistance. So whether osimertinib can be given in second line. Otherwise, it's a relatively excellent drug. In the second, I'm not sure, but it's probably better than afatinib.
Okay, so now we will have Dr. Shyam Agarwal for his final comments on dacometinib. Sir, your take, and what should Pfizer do more to
So first generation, second generation, third generation, all are approved in the first line. So you're not doing wrong if you're writing one over the other. So it's a question of your believing whether you are a sequencing guy. So we are all forced to be sequencing people because people are not able to afford. Only 2%, 3% can go for the third generation. So I think it's a healthy competition, and it all depends on how many lectures we listen from Ullas and how many we listen from Dr. Ranga Rao.
And Kumar Prabhash for EGF
and so on. So it's not two people. So so I think the debate is unending unless you have a head-to-head trial between various options, which is perhaps never going to happen. So we're only going to move forward in the combination era, and hopefully they become affordable so that we can use the best for all of our patients. So it's a very diplomatic kind of a statement, which I think I can afford to make.
I think yes, but I think in my opinion, I would agree that treatment with the first generation TKI in a fit young individual is not really the way to go. Second generation, there were a lot of concerns regarding the toxicity, but I think 30 mg of dacometinib is very easy tolerable. We have just published our 50 patient series of afatinib in non-small cell lung cancer. And the results are good. It's 14.8 months of PFS that we are seeing. And having used them more, we are getting good results. Even with dacometinib, we are getting good results. So I think start with 30 mg and take it from there. So with this, thank you. Thank you all my panelists for a wonderful discussion. And thank you, Shyam sir, for being a sport. And we hand it back to the organizers. Thank you, Shyam.
Thank you, sir. Thank you for a wonderful discussion. It's always glad to hear you out. And now we have another dynamic speaker, Dr. Shyam Agarwal, sir, who needs no introduction. So, sir, we'll be talking about sequence.
It's a question of trying to.
I know, sir. You have already spoken your last slide, sir. I know you have already spoken last slide. Correct. So we'll just hear you out about sequencing of TKI and EGFR mutated non-small cell lung cancer. Over to you, sir.
So I think you have the slides. So the title of the talk which has been given to me is sequencing of these TKIs in EGFR mutant non-small cell lung cancer. So can I have the first slide? And this is a sponsored session by Boehringer Ingelheim. So whatever session is given to you, you have to do kind of justice to them. And the slides are provided by them. So I'm not using any of.
The correct pronunciation of the companies itself is justice, sir.
No, but I think sir, the organizers should spell it now for them. Sushant, tell me the spelling now.
So BI.
You get only 1% of the money for.
The only pronunciation which is difficult is the CAR T cell, Otherwise, atezolizumab and all those things are also not easy to come by. But the CAR T cell is virtually impossible. I haven't even tried because it's not available. So can we have the slides, please, to get going? I think you have the slides.
Yes, they are just projecting it, sir. Yes.
So I think the homework or the spade work has already been done for first generation, second generation, third generation TKIs. And so the idea is to, with this talk, enforce sequencing as to, what is the evidence which we have, whatever we have. So can I have the next slide? And that is vis-a-vis afatinib. So I think these are, this is a slide which I think everybody has seen so many number of times, that, since we are focusing on second generation TKI, it's an irreversible covalent binding of EGFR, ERB2 and ERB4, as opposed to gefitinib, which is only, binding to the wild and the mutant EGFR. Whereas osimertinib is basically only targeting the mutant EGFR. So there are differences at the molecular level in terms of their activity and their binding properties. Next, please. So the idea is, if you are believing in sequencing, which I said we have no choice but to believe in that, because we can't prescribe osimertinib to more than 95% of the cases. Next, please. So this is, some kind of hypothesis which is there for the clonal evolution. So if you use first generation TKIs, you see a lot of heterogeneity in the clone which evolves after the failure of erlotinib, gefitinib, as opposed to afatinib or decometinib. So you can see the EGFR T90M being a predominant clone when patients are exposed to afatinib, decometinib, whereas you can see other types of mutations such as minor mutations or double mutations or compound mutations, etc., when they are exposed to EGFR. So I think that is the main crux here for maybe, looking at second generation TKI in place of first generation TKI. Next, please. So these are the molecular mechanisms of acquired resistance to first and second generation TKIs. And as I think this was highlighted before, that patients who have deletion 19, they have more likelihood to acquire T790M, 75%, and therefore they are more kind of eligible, more patients are eligible to take the third generation TKI, and therefore their survival is likely to be better, and which is the data which is coming up more and more as you, dig into maybe at the moment retrospective studies. There's a big Korean study, 1,000 patients, where they have seen that the T790M, the deletion 19, they do well or better than as compared to L858R. So the other mutations are, small cell, MET, we all know that. Thank you. Sorry, next slide. Next slide, please. So I think this was all, so the issue is, if you are a believer of a sequencing, so if you use the third generation TKI, well, then your mechanisms of resistance are such that we don't have the drugs readily available. Maybe 4 years, 5 years down the line, we have the drugs. But we are focusing currently on the mechanism of resistance and what we can offer to a patient today. So therefore, because these drugs are not available, like MET drugs and so on, to majority of the physicians and patients, you are mainly relying on chemotherapy, which is a very, very poor treatment for patients who are exposed to first-line osimertinib. Next, please. So first generation, second generation TKI, T790M osimertinib minus T790M chemotherapy. But if you use osi, well, then it is only chemo. So this is the basic difference of thought process. Next, please. Next, please. So I think how many patients can benefit from sequencing? So 80% of patients treated with afatinib will receive a second-line therapy. So this is, not, it's like against chemotherapy followed by second line, because you lose a lot of patients when you use chemotherapy in the first line. But if they are on pills like afatinib, more than 3/4 patients will get a chance to take a second line. And as we said, 50 to 70% patients on afatinib will get T790M. So that's a large chunk of patients, especially these DEL19 disease. Next, please. Next slide. Yeah, next. So I think we all are aware. So now now you look at the osimertinib data, when they use it in the first line, so 47% patients received, second line treatment when they were exposed to osimertinib in the first line. And out of those 47%, nearly 70% received chemotherapy. Whereas if you give, gefitinib or erlotinib, you see only 22% patients treated with cytotoxic chemotherapy. So that is the point in sequencing, that you have more patients with T790M who can be sequenced. Next, with the second line or a third generation TKI. So now we have data on geotag, which is afatinib followed by osimertinib, which is a real world study. I think we are all aware of this. This was a global study, observational, 10 countries, 204 patients, and DEL19 L858R. They were given, first line afatinib, and patients who developed T790M received second line osimertinib. Next, please. So the primary objective was to see the time on treatment for afatinib, and it is a single arm study because it is an observational study, and to see the T790M, and the overall survival was also determined. Next, please. So is it applicable to clinical practice? Next. Yeah, surely, because this is real world data. Next, please. Because when you are looking at patients in the studies, you rule out sicker patients which were included in the geotag. So that is 3B4 EGFR mutant, T790M positive were exposed to osimertinib, and a minimum of 10 months of duration is required for data collection. So patients must have initiated osimertinib 10 months prior to data collection. There was no lower limit on duration of osimertinib. I'll explain this subsequently. Next, please. Even if they are taken for 1 day, they would be included in the study. Or patients who had taken less than 10 months of osimertinib would also be, will not be included. So more than 10 months, but then it should be 10 months prior to the enrollment. Next, please. Next slide. So this is, as we said, they had patients of ECOG PS more than 2, and no restrictions on initial dose. 1/6 of patients initiated on afatinib less than 40 milligrams. So which is not uncommon in our practice, also in elderly and people with poor performance status. You tend to start with 30 sometimes, and this is the real world data. More than 35% patients were more than 65 years. No control over lower compliance, polypharmacy, loss to follow-up. Next, please. Next. So next, please. Only consecutive patients fulfilling the criteria were included. As we said, patients with baseline brain mets and ECOG more than 2 were also included. Enrollment was limited to 15 patients per side. No cutoff on minimum duration of afatinib use or osimertinib use, as I showed before. Next. So even 1 day were included if they were enrolled 10 months prior. Next, please. Next. So this is the result of the time on treatment afatinib. So you can see this, I think, spider plot, starting of afatinib and starting of osimertinib. So you see nearly, that is where the median is, which will be seen in the subsequent slide. 10, 12 months, 11 months here. Very similar to PFS in lung studies, which we saw like, nearly 11 months. So this is coming, real world evidence is coming to the same as the trial studies. Next, please. So this is time on treatment for afatinib followed by osimertinib as a whole, 27.7 months in 203 patients who were enrolled in the study. So 27.7 months. Next, please. But then the segregation was done based on various factors. DEL-19, which is supposed to be the best group, had a time on treatment, 30 months. Next, please. Overall survival is different, which I'll come to. Asian patients did even better, 37 months. Next, please. Overall sequencing for overall survival, you see here, is 37.6 months for all the 203 patients. So which is quite good, in the real world scenario. Next, please. 24 months is the 80% people surviving at 24 months, and overall survival in patients who are ECOG more than 2 is also not bad here. So you see 32 months versus 41 months for ECOG 0 and 1. Next. Next. So DEL-19, you see 41.6 months is the overall survival. So which is very, very encouraging here. Next, please. And these people are taking pills. So I think the point which was made in the previous talk regarding chemotherapy, I think I endorse that, because people are not looking for chemotherapy in EGFR mutant, although I believe a lot of physicians are doing chemotherapy and gefitinib based on the Tata data. Asian patients, 44 months, so which is really, really good. You know, there were 50 patients in that subgroup. Next, please. So time on treatment patients with or without baseline metastasis here is, presence or absence, 28 versus 22 months. Next. Older patients did almost equally well, 65 more or less. Next. So this is the summary for time on treatment. If you start from the bottom, Asian with deletion 19, 40 months, Asians 37 months, good performance status 30, deletion 19, 30, without brain mets 28, and brain mets is 22.2. So this is time on treatment. This is, and the overall survival, overall time on treatment for the whole group is 27.7 months. Next. And overall survival is touching, as I showed you, 45 months in the selected, good risk DEL-19 patients. Next, please. So two-year probability of survival is pretty good here, 90%, which is really, really impressive in this sequencing strategy. Next, please. So safety concerns with EGFR TKIs, like you heard for decometinib, you can see treatment discontinuation rates for various drugs in various trials is hovering around 7 to 10%, so which is uniform across the board. Next, please. So dose modifications and progression-free survival in clinical trials. So I think similar data to decometinib. I think actually afatinib was the first one to show that, even if you are giving less than 40 milligram dose, you have a similar PFS like 11 months versus 11.3 months. So you don't lose much. Next, please. So the real GIDO study, which is the dose adjustment study of afatinib, reduces AEs without compromising efficacy with the dose adjustment. And you can see the median time on afatinib for different subgroups is nearly 18-19 months. Next. So this is the afatinib dose modifications. I think we all understand this, that you really need to go down to even less than 40 if the patient is having diarrhea or skin toxicity. Next, please. So I think the battle is, of course, with osimertinib for these first and second generation TKIs. And if you remove first generation TKIs, then it is second generation versus, osimertinib. So I think at the moment, the issue of MET amplification and the use of chemotherapy, puts the sequencing with second generation TKI followed by osimertinib high on the list for EGFR mutants. Next, please. So I think if you're using osimertinib followed by chemo, you have. Can you go to the next slide? Yeah. Next. Next, please. Yeah. So I think this is the first study, GEOTAG, to evaluate time on treatment of afatinib and osimertinib in CLC. And the overall survival in the study is 37.4 months, and even crossing 40 months for, DEL-19 and Asian subgroups, especially with the good performance status. The drug can be used successfully in patients with poor performance status and patients with brain metastasis. So I think afatinib is fairly good, which we've been using now for over 5 years. And I think we all gotten used to using afatinib in the first line for EGFR mutants. Is there another slide? Maybe the last one. Yeah. So I think putting the overall survival in context. So 32 to 38 months with the limited osimertinib usage. Similar study with the decometinib. So, comparable basically. Now you're looking, if you look at these overall survival. But then, I mean, I think anybody can argue against the first generation TKIs also. But I think you need to have cheaper third generation TKIs. Until then, I think afatinib remains pretty high on the cards in my prescription list for EGFR mutants. So with this, I think I'll close here, and thank you very much for your attention, and thanks for the invitation.
Thank you, sir. Thank you for giving this talk. Are there any questions from the audience? I think we have enough discussed about this, sir.
Yeah,
So, yeah, thank you so much, sir. Thank you so much. I would now like to invite Dr. Denny Gupta, who is a senior medical oncologist at Dharamshila, and he will be talking about NSCLC disease overview and long-term survival outcomes with nivolumab in metastatic non-small cell lung cancer. So over to Dr. Denny Gupta.
So good evening, everyone. So now am I audible, Sushant? Sushant, I am audible.
Yes, you are audible. Yes, you are audible.
Right. So I'm going to discuss the role of nivolumab, how far we have reached in metastatic non-small cell lung cancer, as per the usage of nivolumab. So my disclaimer that these slides are provided by the BMS. I am presenting as it is. So. So I am going to discuss in these two headings. First, we know that every discussion starts from a disease overview and treatment landscape, although we are all aware of all these things. And next final discussion is based on the Checkmate 017057. So these were two trials basically which were conducted, I think, in 2015, long back. So these were the first IO which was studied in advanced non-small lung cancer. So briefly about these two trials, 017 was studied in advanced squamous cell lung cancer, and 057 was done in non-squamous type. So both were done in 2015, and as a second line treatment in advanced after first line failure. And 5-year outcome of these two trial combined analysis have been discussed in last ESCO 2020, and final publication of these combined analysis has been out in JCO, I think January or February this year. So we are going to discuss these two trials. Before discussing these, there is a global incidence. As we know that lung cancer is the most common reason behind cancer-related death worldwide, as well as in our part of country. And histology wise, we are all aware that most common is non-small cell lung cancer, majority part, and small cell is 10 to 15%. Among non-small cell, there are another variety, adenosquamous and clear cell, or some other variety also. And we are all aware that majority of the patients we are getting in lung cancer, they are in stage 4. So around 60% of patients are coming to us with stage 4, either metastasis to bones, liver, or brain. Whatever presentation, all presentation we are getting the patients. And problem is that we still have very dismal result. 5-year survival of all these patients are around 4.3% in the US, and 2% if we talk about worldwide. Stages, we are all aware, standard this thing. Treatment landscape is we are going to see. And if we talk about epidemiology in India, and this is the Globocon 2020 latest data which has been out last year. So new cases of lung cancer is 72,510. Incidence wise 5.5 per 1 lakh population. And death we are seeing 66,000 roughly. And 5-year prevalence is roughly around 80,000 in our country. So if we see the treatment evolution in this stage 4 lung cancer, over the last 3 decades, we see initially there was a survival rate of 1 year around 35% only. And over a period of time, it has evolved to 45%. So 1 year survival has increased roughly around 10%, and 2 year survival to 15%. So still it's not very good. And in last stage 4, we have seen that 5-year survival rate is dismal, roughly around 5 to 7%. So therefore, there was a need of second line therapy in non-small cell lung cancer. And around I would say maybe 10 years or back, it was evolved. Docetaxel as a second line therapy was evolved for this type of malignancy. And during those time, the discussion was coming like about PDL1 or PD1 inhibitors for the management of non-small cell lung cancer, although trial was started in 2015. So our treatment decision, we know that in lung cancer depends on so many factors like prognostic factors, means performance status, stage, age, smoking history, line of treatment, weight loss, and how far the patient has been without any treatment. So predictive factor, response to first line treatment, disease control after first line to second line treatment, taking into consideration treatment benefit and toxicities, and obviously patient preference is the last. So this just flow chart is showing that systemic therapy option in patients with their advanced non-squamous cell lung cancer, where they are found to be negative for all driver mutation, which we have discussed in previous discussions, EGFR, ALK, ROS, MET, some more inhibitor if we do the targeted drugs in detail. So all these driver mutations are negative, then obviously what are the treatment options? If performance status is good, we go for systemic therapy. And if it is response is there or stable disease, then obviously there is a recommendation of maintenance treatment. Either we continue the bevacizumab if we have used earlier, or pemetrexed also along with that. Or we can go for switch maintenance also. The role of switch maintenance is also there with the pemetrexed or close observation. These are the options in the maintenance phase. Once patient gets progress, then we have the options with immune checkpoint inhibitor. And we know that as of today, all three molecules have come out with the different trials and different updates. Nivolumab, pembrolizumab, and atezolizumab, all three drugs have come into the picture. Although if patient is not affording, obviously we are using some other chemotherapeutic drugs like docetaxel, gemcitabine, or we are combining ramucirumab with docetaxel also sometimes. If patient becomes PS3 or 4, then obviously best palliative supportive care is the option. On the other hand, if patient is a squamous cell type variety, histology is squamous cell. So more or less, I would say here, pemetrexed is out, bev is out. Only difference is in maintenance. So either continue gemcitabine or switch maintenance with docetaxel or close observation. After progression, options are similar as we have seen in the previous slide for non-squamous cell lung cancer. And all the three ICPIs, or if patient is in PS3 or 4, then best supportive care is the we are left with this option. So finally, we are going to discuss this 5-year outcome of these two trials, which were phase 3 trial, and control arm in both trial were the docetaxel. Before discussing this, they have given one slide for which was also a trial, Checkmate 003. And recently, the update of this trial has also come, 6-year overall survival, roughly around 14.7%. And this overall survival, we are seeing that every year they are coming out with the update, 1 year, 2 year, 3 year, 5 year. So this survival is being maintained for even up to 6 years. Now, if we talk about Checkmate 017 and 057 study design, so more or less study design is same. Only difference is that 017 was in squamous, 057 was in non-squamous. So eligibility criteria, stage 3B and 4 patients were taken, good performance status. 1 prior platinum-based chemotherapy were allowed. Checkmate 017 squamous cell, around 272 patients were taken. 057 non-squamous cell, prior TKI therapy was allowed if there is a driver mutation found in those patients. Prior maintenance therapy was also allowed. So there was a 1:1 randomization with the standard dose of nivolumab and docetaxel. Primary endpoint was overall survival. Additional endpoints were PFS or overall response rate, and efficacy by PDL1 was also analyzed in the subgroup analysis. So they were treated until disease progression or unacceptable toxicity was found. So 5-year pooled analysis of overall survival of both trial, they are showing that they have delivered the 5 times OS rate as compared to docetaxel. Means we can see that with the docetaxel, it was 2.6% 5-year survival. Now with nivolumab, we are having 13.4%, and with the median overall survival of 11 months as compared to 8 months with the docetaxel. So here also we can see the curve. It is separated all throughout. If we talk about 2-year analysis, if we talk about 4-year analysis, 5-year analysis, and maximum, I think median follow-up period is around 69 months as of now, and still curves are being separated, and all throughout this looks like it is still separated even after that. If we see that difference in those patients who are found to be PDL1 more than or equal to 1%, so they also achieve long-term durable OS benefit. as compared to docetaxel. And 5-year this sorry 6 yeah 5-year overall survival is 18.3% as compared to 3.4% in those patients where PDL1 is high they have taken as more than or equal to 1%. On the other hand, if it is less than 1%, even then 5-year survival is 8% as compared to 2% with the docetaxel. So in combined analysis they have shown roughly around 13%. Combined analysis they have shown about 14%. If it is very high, then roughly 18%. Sorry. So this was 18.3% at 5-year. If there is a without high PDL1, low PDL1 is less 8%, means it's working in both irrespective of PDL1, but slightly higher in the PDL1 positive patients. In squamous cell particularly, if you see 017 trial alone, in that also 5-year survival was 12.3% as compared to 3.6 in the with the docetaxel. So it is working in squamous alone also, and non-squamous also there is a good result around 14% as compared to 2.1%. And different subgroup analysis, we can see the forest plot that it is working all throughout irrespective of age group, irrespective of histology, irrespective of PDL1. Although, yeah, obviously slightly better in PDL1 more than or equal to 1, but yeah, it's working all throughout in all the subgroups. At 5-year, if you see that nivolumab demonstrated sustained duration of response with the median PFS was 2.5 months and yeah, 2.5 as compared to 3.5, but duration of response was higher. It is median duration of response was 19.9 months as compared to 5.6 with the docetaxel. This is some interesting analysis in this combined analysis. They have come out that those patients who were PFS, good PFS at 2-year, good PFS at 3-year, good PFS at 4-year. So whatever it was, so they say that whosoever was having the good PFS maintaining at 2-year, so around 76% were maintaining at 3-year also, 68% were maintaining at 5-year also, and 60% were maintaining at 5-year also, and 60% were survivor at 5 years. So similarly, the patients who were progression free at 3-year, around 90% patient of those were progression free at 5-year. So similarly, 4-year progression free, so 88% patients were progression free at 5 years. So this is some unique calculation. They have come out with this combined analysis. And baseline characteristic, if you see the different demographic profile in both subgroup, if patients are less than 1 year survival or more than 5-year survival, we can see that it is valid all throughout in all subgroups in different stages. And treatment status of the survivor at 5-year, we see as per these two combined analysis, around 50%, 50 patients were survivor in the nivolumab arm, and 9 patients were survivor in the docetaxel at 5-year. So starting from the I would say 2-3 around 400 patients. So 400 patients were taken into account in this arm, 400 in this arm, 50 were survivor. So progressed, around 21 progressed and 18 progressed on nivolumab, further did not receive any subsequent therapy, and 19 patients received further line of treatment. So in this way, they are saying that good number of patients were survivor at 5-year, and even they were able to take further treatment in this nivolumab arm. Very less number of patients were able to take further treatment in the docetaxel arm. So we know that standard dose 3 milligram per kilogram every 2 weeks over a period of 30 minutes. Shorter infusion time, it enhances the administration convenience for our patients. Although during corona period, guidelines have come that we can use double the dose every 4 weeks also, and with good equal efficacy and no more side effect, no extra side effect. So if we talk about safety summary of the nivolumab over a time period in this 4 or 5 years, so diarrhea, asthenia, confusional state, edema, hot flashes, so all these side effects are mentioned, but practically if you see the grade 3 or 4, none in these 3 to 5 year follow-up. And maximum side effect was the skin toxicity in the form of eczema or erythema and rash or exfoliation. So maximum side effect is in the skin reaction with this nivolumab arm. So to conclude my talk, so Checkmate 017 and 057 are the first randomized phase 3 trials to report 5-year outcome for a PDR1 inhibitor in patients with previously treated advanced non-small cell lung cancer. And 5-year pooled OS rate was 13.4% with nivolumab as compared to 2.6 with docetaxel, around 5-fold increase. And 5-year pooled PFS rate is also 8% with the nivolumab, 0 with the docetaxel. So patients without disease progression at 2 years and 3 years after treatment with nivolumab had a 60% or 78% chance of remaining progression free at 5 years. So no baseline clinical tumor characteristic clearly distinguished long-term survivor receiving nivolumab, means it is equally applicable both to adeno and squamous as well. At 5 years, 10% of nivolumab survivors were off study drug after 8.8 to 43.5 months of treatment, had not progressed and had not received subsequent therapy. With 5-year minimum follow-up, no new safety signals were identified for nivolumab. There was no evidence of late onset grade 3 to 4 select treatment related adverse events. Thank you.
Thank you, Dr. Denny, for such a lucid talk. Are there any burning questions, or we can take the questions in the end as we are running a little short of time? Any burning questions? If there are no burning questions, then I like to invite Dr. Chandru Gowda, is the Director, Medical Oncologist at Akash Hospital, Dwarka. He would be talking about optimizing treatment outcomes in ALK positive NSCLC, the current and the future trends. Welcome, Dr. Chandru Gowda.
Thank you, SS, Sushant and Samit, for giving me opportunity. Can you see my slides?
Yes, they are visible. Yes.
So today my topic is optimizing treatment outcomes in ALK positive NSCLC, the current and the future trends. So if you see year 2008, where histology as a classifier was used, and we had too many chemotherapeutic agents, and we wanted to differentiate between the chemotherapeutic agents. That era in 2008, that revealed that only around 40% of the patients will be alive after a year. So then came an molecular directed era where ALK was one of them. And in the year of 2017, where Profile 1014 revealed that crizotinib works in this, and it works beautifully. And at that time, the survival increased to 80%. So 80% of the patients were alive at 12 months. So that's 1 year. So that sets in the discussion point that what are the first line treatment for ALK positive NSCLC? What is the current status on this? So in this particular thing, I'll divide my talk into two things, where initial trials were of ALK inhibitors were with only chemotherapy, which was a standard of care then. And then came the second generation, the third generation ALK TKIs, which compared with the crizotinib, which was the existing care after that. So in this regard, the first two trials of crizotinib and azacitidine were pitted against the chemotherapy. Profile 1014 was crizotinib versus chemotherapy with a PFS of 10.9 versus 7 months, which was significant. And whereas ASCENT-4 was pitted against azacitidine with chemotherapy, the PFS was 16.6 versus 8.1 months. So then came the global ALEX study and an ALEX study of alectinib versus crizotinib. So this was against crizotinib, which is a standard of care. The PFS, when you move down the line, so it almost increased definitely more than the crizotinib and the azacitidine, and it is 34.8 months versus 10.9 months in the crizotinib arm. And if you see the recent CROWN trial of lorlatinib, as we see it as a pan ALK inhibitor, pan TKI, which is just recently launched. The lorlatinib was pitted against crizotinib, and the primary endpoint was PFS and by the independent review, and then the secondary one was PFS by investigator, and then overall response rate, intracranial response rate, and the overall survival and the quality of life. So if you see the primary endpoint PFS by independent review at 12 months, 78% in the lorlatinib were disease-free. I mean, there is a progression-free rate of 78%, vis-a-vis only 39% in patients who are on crizotinib. See the median PFS the median PFS was not reached in the lorlatinib arm versus 9.3 months in the crizotinib arm. So indicating that this also was proven by investigator arm, which was the second endpoint. And if you can see the curves separating wide apart and straightening up. So, and see the hazard is 0.21, which is really, really significant. So this is just a summary of the ALK TKI in the first line. There are two more TKIs which have again, other than lorlatinib, which is brigatinib and ensartinib. So these molecules have probably evolved, and that they have resulted in overall response rates ranging from 74 up to 90%. And what is important of these particular drugs from first generation to second generation to third generation is their intracranial overall response rates. That's very important in selecting these drugs. And that ranges in a crizotinib arm not much to serotinib, which goes up to 70%, and in patients who are the alectinib goes up to 80%, and lorlatinib even that is almost similar to what alectinib has in the intracranial response rate. The PFS hovers between 10.9 months with the crizotinib to almost 35 months in all these TKIs, be it alectinib, brigatinib, ensartinib, or it is lorlatinib. So how do you select if you have the confusion in the first line? There are so many drugs available for us, so there'll be confusion. So you need to select on the basis of the efficacy and the volume of disease, the intra and extracranially, and the side effect profile of these individual drugs, and more importantly, the cost. So the cost is very important when you consider India. So first point is an efficacy. So do we have a long-term survival data? So in that regard, we have data from profile 1014, where the survival was prepared against the chemotherapy, and the four-year OS rate in the crizotinib was 56.6%, and the chemo is about 49%, though statistically non-significant because of the crossover. So a lot of patients, almost 80% of the patients were crossed over from chemotherapy to crizotinib arm in this particular study. So then the ALEX study. So in an ALEX overall survival in an intention to treat analysis showed that it is still immature because only 37% of the events have happened. In that regard, you can see that the alectinib median OS was not reached, and in a crizotinib it is 57.4 months. And again, the real world scenario, these are the two long-term data that we have. The other newer molecules we have to wait and see which results in the overall survival. And in a real world scenario, real world OS data according to the subset system and the sequencing of agents, so which was significantly better with the crizotinib, and then followed by next generation EGFR with the ALK TKI, that is 89.6 months compared to crizo followed by chemo and then the best supportive care. So this gives us some sort of an idea to select out which one is better. And the second point is the side effect profile. So the side effect profile of these ALK inhibitors are different from one another. That if you consider crizotinib in almost 14% of the patients resulted in elevated LFT. That is all. What I'm talking about is the grade 3-4 toxicities, and also the visual disorders, the edema and the diarrhea. If you talk of serotinib, we have a lot of GI effects, including omitting elevation of the liver enzymes and the asthenia. But they say that if you use the 450 mg, the incidence of these side effects will definitely be reduced. The alectinib is again liver toxic, but nevertheless compared to lesser compared to the crizotinib. But what is important is anemia and the edema there. And the brigatinib is a peculiar side effect of interstitial lung disease that should be kept in mind. So these side effects will dictate which patient that you need to use this oral TKIs. And this is a trial data of different TKIs and their side effect profile, which is just elucidated. And what happens if a patient progresses on this first line oral TKIs? So we have a data of a lorlatinib of a phase 2 data. It is actually multi-pronged study in which the multiple arms the multiple patients were tested in multiple arms. In the sense, some patients were treatment naive, that is experimental arm 1. Some patients were treated priorly with the crizotinib, that is experimental arm 2. Some were treated with crizotinib as well as chemotherapy, and then some patients were treated more than 2 lines. So these multiple arms, were put on lorlatinib, and then the efficacy was tested. So if you can see the waterfall, in all subset of patients, there was advantage of using lorlatinib. But if you see, the magnitude of benefit depends on how many lines that the patient has been exposed to. If a patient is de novo metastatic, definitely the exponential benefit is much better. So also somebody who has used post-crizotinib. So in all others, the benefit is there, but it is not that robust compared to the first line as well as the post-crizotinib. So this is overall efficacy in the experiment 2 to 5 cohorts. So in experiment 2 of 5 cohorts, in this regard, if you see a prior crizotinib, a prior non-crizotinib ALK-TKI plus or minus chemotherapy, more than one line of previous ALK-TKI with or without chemotherapy. If you come down here, the median, the duration of response, it is not reached if they've used prior crizotinib or any other TKI, and also in more than one chemotherapy. And also the median PFS is 12.5 to not reached and 2.5. And if they used the prior non-crizotinib or more than one line of treatment, the PFS is almost to the tune of 7 months. So this is about that. And then the cumulative incidence of CNS progression and the non-CNS progression. Somebody who has used a prior crizotinib. This is one of the robust data for lorlatinib, where even if a patient has been exposed to a crizotinib prior, the intracranial overall response ranges from up to 70%. And almost these patients, this response is more durable. So if a patient who use lorlatinib post first line of crizotinib, the patients, the durability is almost to the tune of around 14 months. So how do you sequence these agents? So this arm also we say, if you sequence crizotinib followed by lorlatinib, that gives us the longest PFS compared to other sequencing methods, be it seratinib followed by lorlatinib, alectinib followed by lorlatinib, or crizo-seri followed by lorlatinib, crizo-alect or followed by lorlatinib. So in this regard, the crizo-lorlatinib has given us the longest PFS, though we do not have direct comparisons between second and third generation TKIs. So what are the future directions that we need to look into? In that regard, we need to look into the resistant mechanisms, how they develop post first generation TKI or post second generation TKIs. So what are the best combination therapies to overcome this particular resistance that's not mediated by ALK kinase domain, that is like a parallel pathways? Can you delay the onset of resistance with the rational upfront combinations? So, and then can you bring more specificity into our treatment planning by considering the role of fusion partner, which I'm going to tell you in a few slides. So if you see the mechanism of potential strategies to overcome acquired resistance, the acquired resistance of ALK inhibition falls into 3 categories: the amplification of ALK fusion and the mutation in the ALK kinase domain, or it can be a bypass signaling. So if you see the amplification of ALK, the fusion, there the HSV90 inhibitors are playing a role, and probably these are the one which may be added to a current the TKIs, and the future will tell us whether the combination is going to be effective. In the mutation of ALK kinase domain, there are multiple mutations, and there are some resistant, some are gatekeeper mutations. So different mutations. There are next generation ALK inhibitors which are probably changes the way we look into. And the bypass signaling in terms of EGFR, IGF, there's insulin growth factor, and the c-KIT inhibitors, KRAS or a MEK mutant. So MEK inhibitors or SRC inhibitors in combination with the TKIs might give us a more chance of the patient being long control for longer duration of time. So in this regard, we have some preclinical data of our RAS-MAP kinase dependence that underlies rational polytherapy in patients to AML positive lung cancer. There, the addition of a trametinib in combination with seratinib has yielded some sort of better results compared to only one agent. So this is just a preclinical model, and probably this is giving us the thought that this needs to be carried forward. And any talk, if we do not talk about immune checkpoint inhibitors, so here also the ALK inhibition was combined with the immune checkpoint inhibitors. So crizotinib plus nivolumab was combined, but the grade 3, more than grade 3 liver toxicity was very, very high. Hence, this was discontinued. The data of second or third generation with immunocheckpoint we do not know, so that the time will tell us. So as far as the current standard is concerned, ALK inhibition plus immune checkpoint inhibition should not be done due to toxicity. Then what is the role of more precision with respect to the role of 5' fusion partner of the ALK? So we know that EML-ALK and the ALK or the EML partners can partner with the various domains. So those are the variations that you see. The fusion variants of NSLC EML-ALK are V1, V2, V3AB, and these are some of the variants which I don't want to illustrate. What is important from the clinical standpoint is that these variants play a significant role when a particular TKI is used. For example, in a V1 variant, crizotinib is more active, whereas in V3 variant, the lorlatinib is more active. So probably in the future, we'll be able to know more variants, and then we'll be able to select out the better drugs in this particular variations. And now, if you look into the lorlatinib data progress of a patient post crizotinib, you can see the variant 1 with lorlatinib just 3.3 months of PFS, whereas variant 3 has 11 months of PFS. Just was telling you, variant 3 responds well to lorlatinib, variant 1 to crizotinib. So how about non-EML-ALK variants? So there are other, the ALK can combine with other than EML. So those the rearrangements can have different implications, and the drugs are being tried in those non-EML-ALK variants. So this also will give us the idea down the line regarding the efficacy of these drugs in non-EML-ALK variants. And with that, I conclude my talk saying that there are several options available in first-line ALK TKI therapy. The factors to consider in selecting are duration of benefit, extent of CNS activity, the toxicity profile. The optimal sequence of ALK TKI therapy has not been identified in the prospective clinical trials. There are limited data regarding the efficacy of next-generation TKIs after progression of first-line alectinib or ceritinib. However, the lorlatinib has a promise in there. The preclinical studies and the clinical trials are needed to determine the best combination therapies to delay or prevent resistance to all TKI therapy. Thank you very much.
Thank you, Dr. Chandragowda, for such a lucid talk. And in the interest of time, we'll be taking questions in the last. So we'll go on to the panel discussion, and moderator for that will be Dr. Vineet Govind Gupta. Dr. Vineet is a senior medical oncologist at Artemis, Gurgaon. Sir, you are welcome.
Yeah, thanks, Dr. Vineet.
And may I invite his panelist also, Dr. Novak Gupta, Dr. Abhishek Raj.
Yes, sir. Present.
Dr. Mukesh Patekar. And Dr. Nagendra Sharma. Hi, Dr. Nag. Dr. Novak, are you there? Over to you, Dr. Vineet.
Thank you, Dr. Sumit. So, good evening to everybody, and I have one very esteemed panelist available with us today. And really, what I'm going to discuss are some questions where actually sometimes even I don't know the answer, and I'm sure practice varies greatly from consultant to consultant. So we just want to make some sense how practice is moving and what direction everybody is taking there, the way they treat their patients. So we have a case here. She is a 65-year-old female, non-smoker, presented with pleuritic chest pain, found to have pleural metastasis, biopsy, adenocarcinoma, TTF1 positive, NAPSN positive, and we send the tumor block for genomic testing and PD-L1 with a turnaround time of 1 week. So this is quite a frequent scenario where patient has high disease burden and you have to start therapy and the genomic testing report will come in 1 week. So for my first question to Dr. Mukesh, so what kind of therapy do you do in these kind of patients where you are waiting for the genomic report? So is it PEM carbo, paclicarbo, some combination with immunotherapy or anything else?
Generally, I start with a PEM carbo combination most of the times. And that gives a rapid relief to the patient symptoms, and we buy some time before getting the genomic results.
Does anyone like to use immunotherapy in this setting before getting the genomic reports?
No, because adding immunotherapy first cycle is not going to make much difference. We can definitely wait for 10-15 days time. If all the genomic driver mutations are negative and PD-L1 is positive, then we can definitely add from second cycle onwards. So definitely I will go for PEM carbo combination if it is adenocarcinoma. It is adenocarcinoma.
Dr. Nagendra, do you agree?
Yeah, I do agree, sir. But Dr. Mukesh have told, the majority of times we will use platinum doublet, and adenocarcinoma pemitic carboplatin is preferable till the reports are awaited in a patient who's having a high burden disease.
Okay. Anybody disagree, Dr. Novak or Dr. Abhishek?
No, I follow the same practice. Patient is a female, very likely to have some targetable mutation present in her. So I'll just use pemetrexate carboplatin and wait for the genomic report and then change my therapy accordingly.
What if the patient is male and smoker? Will it change your approach?
No, again, chemotherapy doublet only I'll use.
Okay.
And
so
if later patient is PD-L1 positive, probably I would like to add immunotherapy then.
If the patient is having adenosquamous histology, then what should be the choice of drug?
You tell me, Dr. Nagendra.
Sometimes I think many times we face this type of clinical problem. When histopathology report is mixed histology, then we are always in a double mind whether we should use pemetrexate or paclitaxel with platinum. So I just want to take opinion from my other co-panelists, what they are doing in their clinical practice.
Okay, I think we will discuss this in the end because the session is on ALK. So we have a lot of questions ahead. We'll discuss this also. So let us assume that we started pemetrexate and carboplatin in this patient, and patient seems to be improving. Meantime, patient come positive for ALK as well as PD-L1 both. So the D5F3-IHC is positive and PD-L1 is 60%. So, to Dr. Abhishek, yes. When would you like to switch the patient to TKI? Will you complete the chemo, complete the maintenance, then switch? Will you interrupt immediately and switch?
I will interrupt immediately and switch to TKI. That's what I do.
Even if patient is improving clinically?
Yeah, still.
Okay. Dr. Novak, do you agree, disagree?
I think this patient has a, the disease burden was very high. Maybe I would give 2 cycles and then go ahead with the TKI.
Okay. Dr. Mukesh?
I do agree with Dr. Abhishek. I'll interrupt the chemo and definitely shift to the TKI immediately. As we have seen that TKI also it has good response rate. It works as good as chemo or better than chemo.
Yes, exactly.
Yeah, it is not lymphoma-like situation. So definitely TKI.
Okay. So some relevant things with my first question. So all the studies of chemoimmunotherapy, none of them has first-line EGFR ALK positive patients.
Yeah.
Even in the Empower 150 study, patient had to be exposed to at least one ALK TKI. One more reason it might not be a good idea to start with immunotherapy before getting your EGFR report is that if you give the osimertinib later, it might lead to severe pneumonitis. So I think the panel mostly agrees that we should wait for the genomics report before starting immunotherapy.
Even the Dr. Vineet, even the response rates to patients who are PD-L1 positive and they are targetable mutation positive, I think it is lower as compared to patients who are not.
So the when we talk about chemoimmunotherapy combo, the data is not very good in EGFR ALK patients, especially in the first one. So I do agree. So let's come to the main question. So this lady has been, suppose we have not given any chemo and funds are no bar, brain is clear, PD-L1 60% and ALK positive. So which is the preferred therapy for your patient? So let's start with Dr. Novak. What is the drug you would give if patient is absolutely affordable for every therapy?
So I would generally be inclined to use alectinib as first line.
Okay. Any of the other panelists want to use lorlatinib upfront after the publication of Crown study? Dr. Abhishek?
I think I would go with alectinib only. There is no head-to-head comparison between alectinib or lorlatinib. Plus, alectinib resistance, we always have a chance to use lorlatinib later on.
Dr. Nagendra?
I do agree with Abhishek. If funds are no bar, then definitely alectinib is the first choice in this scenario.
Okay. Is there any patient population, Dr. Nagendra, where you would use lorlatinib upfront instead of alectinib? Suppose some patient has got a lot of brain mets. Will it change your decision?
I do agree. Your question is absolutely pertinent. The point here is, as far as TKIs are concerned, as the previous presenter presented, that the choice of TKI depends on what is the efficacy, what is the volume of the disease intracranially or extracranially, side effect profile, and the cost of the drug. These are the factors we take into consideration before selecting the drug. In a patient who is having not having brain metastasis, then if affordability is not an issue, alectinib is no doubt about is the godfather of all TKIs as of now. But now Crown phase 3 study, which is published, there are excellent results because the overall survival and median PFS have not yet reached, and the CR rates is 71%. So that is now if we can see the intracranial response rate is 82% with crizotinib. For lorlatinib. So, and quality of life also is one. Only thing is the side effect profile, which is a little bit bothersome. Otherwise, lorlatinib right now it is challenging the godfathership of alectinib.
So the reason for not using lorlatinib is the side profile for you, am I right? Or you feel that we need more data?
We need more data because we are having a hands-on experience with alectinib as of now. We are more comfortable with alectinib, the way the responses are presented and the overall survival and PFS advantage. But maybe future that lorlatinib can challenge alectinib, because only in variant 3, as the sir presented, lorlatinib is having a better responses. So as of now, alectinib, but in future we are optimistic. Maybe lorlatinib can challenge alectinib once the overall survival is published.
Dr. Vinny, lorlatinib, maybe I've not had any kind of hands-on experience, but it's reported 40% of the patients have a neurocognitive, problems. So I think that's quite significant, maybe.
Okay. So luckily, I have had the chance to treat around 15 patients, and so far I have dealt with a problem in only one patient. So it might be the data describes it, but I think most of the neurocognitive effects are very subtle. So I just want to discuss the study results with you, Dr. Novak. Looking at the difference in PFS, and would you, even for a patient with brain mets, you would choose alectinib over lorlatinib?
So see, the thing is with brain mets, probably my inclination would be for lorlatinib. But apart from that, most of the other patients, maybe alectinib would be the preferred thing. With the Alex, JLX, and the Alicia, alectinib, the response rates are more than 80%, 82%, 90% by far, which is quite significant. It's very good to have such kind of response rates and the PFS reaching up to 3 years. So that's, I think probably you've got very good results. And lorlatinib, even though the data seems to be very promising, I believe maybe we need more, more mature data to go ahead giving this drug as frontline.
Dr. Abhishek, in a patient with brain mets, frontline lorlatinib?
See, the data, as everybody rightly said, the data is very promising. Very good, excellent response rates in patients who have CNS metastasis at baseline. But even the CNS penetrability of alectinib is pretty good. Plus, we have got a longer data for alectinib. I'd probably go with alectinib first.
So I think the consensus for most of the panelists to go for alectinib, which I think is justified because of the longer data and the better toxicity profile. In fact, recently, long-term survival data of Alex has come out, and there seems to be an emerging OS benefit.
Yeah.
So although the data is still not mature, so I think most of our panelists still want to go for alectinib. Not to mention it is considered less toxic as compared to lorlatinib. But practically, I will tell you, most of our patients who come to our clinic start with crizotinib or ceritinib because of cost issue. So let us assume our patient was started on crizotinib, achieved PR. So we see this kind of patient all the time. So this is one patient of mine who has completed 3 years on crizotinib and still has a very good response, persistent. And we see this kind of patient all the time, having years and years of response. So suppose at 3.5 years follow-up, the patient presents with multiple small CNS mets and systemic disease is still in remission. So question, you would go for whole brain radiation or not? And would you go for alectinib or lorlatinib? Or even whether you would want to give whole brain radiation and continue crizotinib? So Dr. Mukesh, please, I would like to get an input from you.
In this case, if patient, there are very small lesions, and I think the patient is not symptomatic. So straight away we can go for TKI maybe with alectinib or lorlatinib, whichever is available, and definitely both have high intracranial efficacy. So both are going to work.
Dr. Novak, alectinib or lorlatinib?
Yeah, see, I think Dr. Vineet, this is what is, what is probably anticipated with ALK inhibitors. Any first generation, probably over a span of time, he's going to develop some kind of acquired resistance, and this is what is going to happen. For this patient, not, but otherwise, most of the times I try to, what I want is to get a biopsy, rebiopsy, and work on it. But maybe for this patient, I would be wanting to go ahead with the RT and then continue with crizotinib. A local therapy and then just continue the TKI.
Okay, so that is definitely very much a valid option. And Dr. Abhishek, do you agree with this?
Yes, it's a good approach. Considering that our patient opted for crizotinib upfront, that means the patient had financial problems. So going ahead with WBRT and continuing crizotinib is a very good idea. But since the patient does have progression, I would probably, in an ideal world scenario, I'd probably go for alectinib and no RT, because the patient has an excellent intracranial response rates with alectinib as well as lorlatinib.
And I have one reservation for WRT in continuation of crizotinib. If you have a good molecule to which have a high CNS penetration, why to subject patient for WRT and continue the same regimen rather than giving the newer and which are likely to give more benefit. So that is my take on this.
Another point will be, Dr. Vineet, that if the patient is receiving WBRT, and we know that even with second line therapy, the patient can still live for another 3 year, 4 year probably. So the chances of neurocognitive defect, particularly with lorlatinib, is going to be higher if you're subjecting the patient to RT. So I think just giving a TKI would be a good option.
These are very valid points. Dr. Nagendra, for you a different question. Yeah.
Can I add one thing, sir?
Yes, please.
I just want to tell you that if the patient is having multiple small CNS mets, WBRT with the hippocampal smearing should be considered because of neurocognitive decline which can happen with this.
But would you like to give WBRT in an asymptomatic patient? Just
no, that's
there is no fixed guideline, but what would you prefer to do?
Right, that's a radiation oncologist call depending on the number of the lesions and the sites and the size of the lesion. Second thing is the crizotinib, there is an issue with that. There is a drug efflux pump, that PGP and BCRP pump, because of which the drug will be effluxed. So continuing crizotinib may not be a good idea. So in this type of patient, either you switch over to alectinib or lorlatinib for that matter because of higher intracranial efficacy. But in a medical legal era, it's always better to use RT, hippocampal smearing, followed by a switch TKI with alectinib or lorlatinib if you cannot confirm with the biopsy, because the systemic disease is still in remission.
So Dr. Abhishek and Dr. Mukesh, you opted preferably not to give radiation. If the patient had mild headache which resolved with steroids, would you still want to omit RT?
Yes, I would still omit RT. I think I would still omit RT, Dr. Vineet.
Okay, Dr. Mukesh.
The response rates in the JLX trial and LX trial were excellent, and mildly symptomatic patients responded beautifully to this drug.
Okay, Dr. Mukesh.
Yes, we can wait and closely observe. If patient has persistent symptoms, then definitely we can go either way for WRT. If patient responds, then we can wait.
Dr. Novak, still crizotinib and RT, that would be your choice, correct?
It's good that we are not doing any radiation oncologists in our panel.
No, but in this kind of scenario, I think the radiation oncologist might ask you, sir, what do you think? Will the tablet alone take care of it? So you may have to be the deciding person, Dr. Nigandhu. So I think I'm just showing the NCCN guideline here. It offers all of these options. Actually. So there is nothing wrong, and definitely radiation is still a plus minus, and it is an evolving treatment. These slides are presented by Dr. Chandra Gowda also. So you can see actually that CNS control rates are very, very good with new class of therapies like lorlatinib and alectinib. So in lorlatinib, in fact, you can see that patients who were previously treated with crizotinib, like our patient, there were no disease progressions. So response rate of 87.5% and 12.5% stable disease. So definitely I would say I agree with those who would like to wait for radiation, which might have long-term effects. Alectinib, cumulative responses were 18% CR and 43% PR. But so that is also one very valid option. So we can see the cumulative incidence of CNS progression with crizotinib versus alectinib compared to lorlatinib versus alectinib, and the hazard ratio is 0.06 in fact. So very, very impressive with lorlatinib. So at 3-month follow-up, our patient comes with cholesterol of 350, triglycerides of 500, fasting blood sugar of 250, and complete remission of brain mets on MRI with lorlatinib. So I would like to ask Dr. Nagendra, have you treated any patients with lorlatinib so far?
Only one patient I'm having in which the disease has progressed, and we've used lorlatinib post first line progression. And this is the typical problem which happens majority of times, which we encountered, that hyperlipidemia and these are the side effects which you have mentioned in the slide. So this is which is bothersome, and we have to manage that with the additional medications.
Dr. Abhishek, your experience?
So I recently had one patient and I reached out to you that what I need to do. The patient had a very severe edema. It was interfering with her day-to-day life, and she had even pulmonary edema. So I started her on diuretics, but it did not help much. So I have recently reduced the one step lower I have done. I've started her on 75 mg, and she's feeling much better. Even the edema is gone, and her weight has reduced. So lowering a dose once the patient has achieved a response, I think it's a good idea.
Dr. Mukesh?
I have only 2 patients when I treated with on compassionate access, but they unfortunately died within a 3 to 4 months as I got drug delayed delivery. So I don't have much experience with this kind of side effects. So you are the best person who can guide us.
Dr. Novak, have you any experience with this medicine?
So I don't have any kind of hands-on experience as of now with lorlatinib.
So I'll just, because fortunately we have a phase 4 trial of lorlatinib at our center, and we have around 15 patients, which is the second highest number in India. So far I have not faced any patient with heart block, but dyslipidemia is extremely common. All of our patients, 100% are on statins. Edema is somewhat common. Hyperglycemia occurs occasionally, and CNS effect we saw in only one patient, where we had to do a dose modification. But so far, luckily for other side effects, we have not had to do dose modification. So overall, with good, metabolic medication, it seemed to be a reasonable, tolerable drug. I have not faced very, very severe problems in most patients. Okay, so now comes to the last question, and now I think in the current era, all of us oncologists need to become molecular oncologists, and we need to understand what is happening at the molecular level in the tumor and go to the preclinical settings as well. So as Dr. Chandragoda described in the last few slides of his presentation, if the patient has a polymetastatic progression on lorlatinib, first question, would you rebiopsy and send for NGS? And which of these options you would like to use? So Dr. Novak, could we start with you, please?
Yes, so see, I would want to do rebiopsy and send for NGS, even though most of the times it is very difficult at our center. But this is what I would want to do, and I, try to push the things to get this done. That is the first thing. The second thing is, my option amongst all this would be the IM50, the chemo with immuno with BEV, maybe with a PEM carbo combination along with the the IO and a BEV.
Okay, Dr. Mukesh. Same regimen you would choose?
No, I'll do biopsy in NGS followed by chemotherapy alone, because if you look at the experience with the immunotherapy plus chemotherapy, they are not that much good, and I have not used this triple quadruple drug combination. So I would like to go with chemotherapy in the patient still likely to respond as they are chemo naive, and look for the NGS results.
Dr. Abhishek?
Yeah, I agree with Dr. Mukesh. I would not like to use immunotherapy because in the targeted mutation, the patients who are already targeted mutation positive, the response rates are not very good. So I'd probably go with just immunotherapy, and definitely yes, do the NGS if the patient is affordable.
Dr. Nagendra?
Absolutely right with my other co-panelist opinion. So majority times, like if you use alectinib in the first line, and after which patient have progressed and polymetastatic systemic progression is there, and then patient have we have sent for NGS. So majority times they are financially exhaustive. They are exhausted. So in that case, majority times either chemotherapy also is an option or chemo plus minus immunotherapy, but you have to take call based on NGS reports majority of times.
So suppose you get the NGS report and it is negative, you don't see anything except the ALK mutation. Would you like to add immuno at that point?
I'm not able to understand your question. Can you repeat once again?
Suppose you start with chemo and the NGS report does not show anything targetable. Would you add immunotherapy to chemo at that point?
The PD-L1 percentage will drive the decision. Like if it is on the higher side, then chemo plus immunotherapy also can be considered. So we are having not strong reservation, but this is all gray zone because there's no yes or no answer to this question. So we have to think twice, and we have to the financial status of the patient will drive the decision.
Okay. So yeah, so actually most of these questions are gray zone questions, and I actually wanted to pickle your brain so that I understand how you would approach the situation. Dr. Abhishek, same question. If the NGS is negative, will you add immuno with BEV if the patient has no financial problem?
I would just treat him with chemotherapy at this point, Dr. Vineet. Maybe at the time of progression, I can discuss it with the family. We can, when we don't have any other option left, probably that might be the time when I can add this single agent immunotherapy.
So the study which Dr. Novak spoke about was this one. And in this study, the patient with EGFR ALK subgroup also seemed to have some benefit. Of course, it is a subgroup analysis, but this is actually the only study which has shown any benefit in this particular subgroup. Empower 130 was atezo nab-pac carbo, which failed to improve PFS in 41 patients with EGFR ALK. But of course, it is a mixed population. It is a sub. Don't know how best to inculcate immunotherapy in these patients. Like Dr. Chandragowda showed, if there was a disproportionate high toxicity with immuno-TKI combination, so we need to know more. So I was just looking at some of these case reports for the purpose of this presentation. So far, so there have been some publications where patients have been treated with crizotinib after lorlatinib failure, and in fact, some patients have responded, which is maybe contrary to our expectation. There is even a case series where they have shown that a very high proportion of patients have met alterations, and they can be targeted with a crizotinib-lorlatinib combination. So like you can see in the diagram below, patients who were found to have met alterations, they achieve tumor shrinkage by addition of crizotinib, which also inhibits MET, unlike lorlatinib. And of course, a histological transformation, which is why I also agree that biopsy is a good idea in the post-lorlatinib setting. So that's it. I thank my panelists a lot, and I think we are well in time, and I will hand over back to the organizer. Thank you. Thank you, Dr. Novak, Dr. Abhishek, Dr. Mukesh, and Dr. Navinder.
Thanks.
Thank you, Vineet.
Thank you, Dr. Vineet, for conducting such a wonderful panel, and thank you all panelists. Now I'd like to invite Dr. Malhotra, sir. He needs no introduction. Sir is a renowned medical oncologist, not only in Jaipur, but all over India. So I'll request him to take over the session. Thank you, sir. Thank you for coming.
This session is sponsored by Eli Lilly.
Thank you very much, Sushant. May I share my screen now?
Yes, sir. Please, sir. Please go ahead, sir.
Okay, can you see my slides?
Yes, sir, we can.
Okay,
and they are moving also, sir.
So thank you very much. I'd like to start with thanking Sushant for this opportunity. And after so many years of being in oncology and attending lots of conferences and lots of webinars in the past 1 year, one of the most important yardsticks of a successful conference/webinar is that it has to be on time. And I congratulate the organizers for, sticking to time. And I will also try and do that. My brief today is to talk to you about using a VEGF inhibitor, ramucirumab, in combination with the EGFR TKI in patients who have EGFR mutated non-small cell lung cancer. And we will only cover the approved indications and we will not cover any unapproved indications. And if we have time, we will take questions also. So I will do a 15 to 20 minute background introduction talk. and then I'll request Dr. Vikas Talreja to talk on the pivotal study of this combination, and then I'll conclude in the next second session of the 2 to 3 minutes. And these are my disclosures. This is basically a Lilly sponsored symposium. So ladies and gentlemen, in oncology, we know that this question, does one size fit all, is being answered more and more in the negative connotation. And as we are learning more, we are learning the biology of the tumor, we are learning the genetic interplays in the tumor, we are realizing that the same disease, the same stage, still requires different treatment. And I think that is also what is happening now in non-small cell lung cancer who have the EGFR receptor mutation. So this is the whole gamut of first-line EGFR TKI trials, and we are talking only about patients of NSCLC who have the EGFR mutation. The first studies are here, gefitinib first-line TKI studies, elranatamab, and then the second-generation TKI studies. You can see that across the board, the TKI fares better with respect to response rates, as well as PFS, as well as OS when compared to chemotherapy. And that is why the TKI has become first-line treatment in patients who have the mutation. With the first generation agents, you can see that the PFS ranges from about 10 months to 12 or 13 months. With the second generation TKI, a few months addition, 11 to 12 months, 14 months. And now with the latest third generation TKI, we are approaching a PFS of about a year and a half. And these are the first generation TKIs, these are the second generation TKIs, and this is the third generation TKI, which fortunately is also available to us in India. Now we also have a new concept coming up that in addition to the tyrosine kinase inhibitor, can you combine it with something to add to the response, to add to the PFS, and hopefully add to the overall survival. So we have this wonderful study from our own Tata Memorial Cancer Center presented at ASCO. First author, Dr. Vanita Narona, combination of the first generation TKI with chemotherapy. And it did show an improvement in PFS. A similar study from Japan, again, a little better PFS as compared to the TKI alone. One more study from Japan. And then this is the pivotal study which we will kind of focus on today, the combination of the first generation TKI erlotinib with a VEGF inhibitor ramucirumab compared with only the TKI. And you can see that the PFS with the combination of the TKI and the VEGF inhibitor is approaching almost 20 months. So now, ladies and gentlemen, this is where precision oncology comes into play when we talk about EGFR mutations. And we are now beginning to realize that all EGFR mutations are not equal. Like a few years back, say about 5 or 10 years back, what we were interested in was, does the patient have an EGFR mutation or the patient doesn't have an EGFR mutation? And all patients who had the EGFR mutation would be started on a TKI, either first generation or second generation. But now we are beginning to realize that patients who have deletion of exon 19 behave differently. Patients who have exon 21 mutation, the very common L858R mutation, they behave differently. Patients who have exon 20 insertions, they behave differently. And the patients who have less common EGFR mutations, they have to be looked at in a different way. And you're aware that these are the two most common mutations which we see in clinical practice, comprising almost 80 to 90% of all patients. And here is the same in more details for you. Exon 18 mutations are seen in about 5% of patients. Exon 19 deletions are seen in about 50% of patients. Small number of patients, about 3%, less than 5% have exon 20 T790M mutation. And we know that this is the mutation which comes up most frequently when TKI resistance develops. And the second most common mutation is exon 21 L858R mutation. So if you add this to this, almost 90% of your patients who have an EGFR mutation will have either exon 19 deletion or an exon 21 L858R mutation. Now, there has been this indirect meta-analysis of 6 studies, more than 1,300 patients, in which they have analyzed whether the exon 19 behaves the same as exon 21 mutation. And they have found that patients who have exon 19 mutation do significantly better than patients who have exon 21 L858R mutation. And this is the hazard ratio for you, whether you use a first generation TKI or you use a second generation TKI. There is a difference in PFS if the patient has an exon 19 mutation versus a patient who has exon 21 mutation. Patients who have exon 19 mutation, they do significantly better than patients who have exon 21 mutation. Now, this could also translate into the fact that maybe exon 21 mutations require something else, something other than a first generation TKI or a second generation TKI. So we've already talked about this significantly reduced risk of disease progression in patients who have exon 19 mutation versus who have exon 21 mutation. And you can see the same in the forest plot. To the left of Unity are patients who have exon 19 deletion. To the right of Unity, you have patients who have exon 21 deletion. And then again, this direct meta-analysis, 7 studies, 550 patients, very clearly conveys to you that when you talk of progression-free survival, it is better in patients who have exon 19 mutation. So I think this is clear to us that these are two different diseases, even though they both show the mutation in the EGFR receptor, they are possibly different diseases. So to emphasize the same to you a little more, patients who have exon 21 mutations typically have more modest PFS as compared to exon 19 mutation. And this is the top level is patients who have exon 19 mutation, and this is patients who have exon 21 mutation. And across drugs, even the third generation TKIs, PFS 21 months versus 14 months. This is with osimertinib. And then the Lung-3 trial, PFS 13.8 versus 10.8. And the Eurotrack trial, 11 months versus 8.4 months. So like again, reiterating to you that in patients with exon 21 mutation, PFS is not more than a year and a half, even not more than a year and a half with currently available single agent EGFR TKIs. Now, this is the afatinib versus cisplatin trial compared to EGFR, compared to only afatinib, and you can see that the combined analysis, overall survival, afatinib is superior to chemotherapy. And here, look at the subgroup analysis. Again, hardly any benefit or possibly no benefit in patients who have the exon 21 mutation. All the benefit is in patients who have exon 19 mutation. And overall survival was only improved in patients who had in the exon 19 mutation subgroup, and there was no effect if the patient had exon 21 mutation. So these are different diseases. And here is the same, this is the FLORA study. And here again, you can see the red arrow over here. These are patients who have exon 19 mutation. These are patients who have exon 21 mutation, and very little benefit in terms of overall survival even with our third generation agent if the patient has exon 21 mutation. This is the Archer study of dacometinib, and again the median PFS was 12.3 months in patients who had exon 21 mutation versus 14.7 months in patients who had the exon 19 mutation, and again this was a significant hazards ratio. So now here is the relay study, and this is going to be covered in details by Dr. Vikas in the subsequent talk. And the relay study, just to kind of give you an overview of the same, was a randomized head-to-head comparison of ramucirumab plus erlotinib versus placebo plus erlotinib, and the progression-free survival here, exon 19 mutation significantly better in the VEGF inhibitor plus TKI inhibitor arm, and also in the exon 21 mutated patients, this was significantly better, the combination of ramucirumab with erlotinib as compared to only erlotinib. And this was the big difference in this study as compared to other studies. And you can see the numbers over here, median PFS 19.4 months, with ramucirumab erlotinib in exon 21 mutated patients as compared to 11 months. And this is as best as it gets, very significant hazard ratio. So it does kind of convey to you that at least in this one pivotal study, the combination of ramucirumab with a first generation tyrosine kinase inhibitor, whether the patient has exon 19 mutations or the patient has exon 21 mutations, the benefit is very consistently the same, and this is significantly better than even the second generation TKIs and possibly also the third generation TKI. So again, to come back to this slide, we are now beginning to believe that all EGFR mutations are not equal, and exon 19 mutation patients have to be dealt differently, and exon 21 mutated patients have to be dealt differently. So I think we've already talked about this, and in the interest of time, I will just skip over this. And again, this is reiterating the same thing, that patients who have exon 20 insertion, this is an uncommon mutation, they need to be treated differently, and new tyrosine kinase inhibitors are being developed for this. This is a new agent, positinib, and you can see the very good response rates of this particular agent in exon 20 insertion patients. And again, to reiterate the point that all EGFR mutations are not same, and each one has to be addressed a little differently. So for the patient with exon 19 deletion, historically this subgroup has achieved better outcomes than the exon 21 mutated patients. Both the third generation agent osimertinib and the second generation agents have demonstrated a substantial progression-free survival benefit. Now, if you talk about the next most common EGFR mutation which we see in practice, the exon 21 mutation, median PFS has yet to cross a year and a half with most available single agent TKIs, and this includes the third generation TKI. But we are seeing very promising results in this subgroup when you combine your TKI with a VEGF inhibitor, ramucirumab, and that is what is the substance of our this CME today, and we will talk about the pivotal trial in a few minutes. So how can you maximize the benefit of EGF targeted therapies? A first generation TKI followed by osimertinib in T790M mutated patients. This is a resistant mutation, and osimertinib is the only agent which works in this. So this is probably the way to go if the patient has a T790M mutation. But there are issues of availability. If the patient has CNS metastasis, then of course, again, that is a very strong point in favor of using osimertinib up front, because this agent has the maximum penetration into the blood-brain barrier. Now, what about using the regime of a second generation TKI followed by osimertinib in T790M mutated patients? This again, it does appear as per current data that this is a strategy which is inferior to this strategy. Now, osimertinib in the first line in all EGFR mutated non-small cell lung cancers, again, you have issues of cost, but if the patient has brain metastasis, this might be the option of choice. What about chemotherapy plus first generation TKIs as exemplified by the Tata Hospital trial and by the Japanese trial? Little more toxicity to this, but it might be the way to go for fit and young patients. And it might be a cost-effective way in our country where the second and the third generation TKIs, there are no generics and they are extremely expensive. Now, this is the new kid on the block, the new combination, the combination of a TKI with a VEGF inhibitor, followed by osimertinib. This might be close to the ideal strategy, particularly for patients who have exon 21 mutation. And you can see that if you use this strategy, combination of erlotinib with ramucirumab, according to the delayed trial data, you can expect progression-free survival of almost 20 months. And once the patient progresses, if you put the patient on the third generation TKI, you get another 10 months. And then if the patient progresses on the third generation TKI and you give the patient chemo, and the patient gets another 4 months, and your patient can live up to almost 3 years. And this is close to the best you can get with all the permutations and combinations you have available to you today. And ladies and gentlemen, my apologies for the fine print over here. I'd like to tell you that this combination, the combination of ramucirumab with erlotinib is now approved in our country in patients who have non-small cell lung cancer and activating EGFR mutations. With that, I conclude my talk, and it is my pleasure and privilege now to invite Dr. Vikas Talreja to talk about the pivotal study which led to the approval of this combination. Dr. Vikas, are you there and are you ready?
Thank you, sir. Thank you for the kind introduction. And thank you, Lily, for providing us a platform. I won't be making your dinner a little late, but yes, I would be giving a slight brief about why we are discussing at around 9:15 on a weekend for this beautiful study that has led to more confusion, or I have the privilege to say that it has given us a beautiful option in a subgroup where we were confused as to what to do and what not to do. And may I have my slide set, please? So that so we will be discussing the pivotal study of the relay, which is the ramucirumab plus the erlotinib in the patients with untreated EGFR mutated advanced non-small cell lung cancer, the randomized placebo-controlled phase 3 trial, where Cyremza, how it is different from the other anti-VEGF. So Cyremza, it binds to the VGFR2 and therefore it blocks the multiple ligands, the VGF-A, the VGF-C, and the VGF-D. They have shown to induce angiogenesis in the preclinical studies, and with the specific binding of the VGFR2, it blocks the multiple ligands binding to a single receptor, and therefore has a downstream much more deeper, better, and more efficacious inhibition rather than the non-specific VGFR we had in prior to. And when you give this combination with another VGF combination, so when you combine Cyremza with the erlotinib, it adds to the efficacy. So you are inhibiting the VGF, you're inhibiting the EGFR, and as we say in science, it is always the 1 + 1 is never 2, it is more than that. That's the synergism between these two combination tumor pathways because they interlink together a lot. So it's not a angiogenesis pathway as separate, EGFR pathway as separate. They are interlinked pathways, and therefore the dual blockade of the VGFR and the EGFR signaling pathways has shown uh, uh, more than 1 + 1 = 2 effect. That is a more synergism effect with more inhibition of tumorigenesis, more inhibition of angiogenesis, and downstream inhibition of multiple pathways. So the RAS, RAF, the PIK3CA, the mTOR pathways, which are all a notorious pathway downstream, are inhibited by a single molecule and combination of it in a beautiful manner. So that was the preclinical concept of putting this trial, a combination of a VGFR and the EGFR, and therefore the inclusion criteria was very simple. The stage 4 lung cancers, the most common two mutations, exon 19 deletions, exon 21 L858R, and a performance status. Those who had brain metastasis, those who had prior treatment with EGFR TKIs, those who had a T790 mutations, they were all excluded, and they were stratified based on the exon 19 deletion versus the exon 21 L858R mutations. The East Asians were separately separated, and also the EGFR testing method, whether it was the TheraScreen COBAS versus the other method, and the sex was the stratification factor for it. So how they were given: erlotinib given in 150 milligram once daily, plus the geftinib, plus the ramucirumab 10 milligram per kg every 2 weekly, vis-a-vis placebo was plus the erlotinib. The primary endpoint was the progression-free survival, and the secondary endpoints were the safety, toxicity, OS, response rates, disease control rate, duration of response, with an exploratory biomarker analysis. Next slide, please. So baseline characteristics fairly balanced between it, since it was a randomized trial, all thing fairly balanced. One thing that I have to give you a very particular note is the look at the EGFR mutation at the randomization. So fairly balanced between the exon 19 and exon 21 L858R mutation status. Again, very important specifically for our subgroup. And here comes the blockbuster news for everybody. When we think of the placebo arm, we were giving just erlotinib. Next slide, please. We expect most of the times the people to survive without a progression for an year about, and that was there 12.4 months. Addition of Cyremza, so the synergism which was I was talking to it, if you look at it, it is 19.4 months, so more than 1.5 years, I say, close towards the second year mark. You could see most of the patients were without any progression. The hazard ratio being 0.591, which is a very high hazard ratio, nearly a 41% reduced risk of progression if you are given the combination of Cyrenza and erlotinib as compared to erlotinib alone. I know we have a lot of debate, a lot of uh, controversies as what could be. We have a lots of options right now for the EGFR mutation, but yes, if we put forward the rest of these options, we also have to consider this beautiful option also, because the combination surpassed any of the parallel marks. So if we look at the cross trials, which we shouldn't be doing, but yes, then this number is a number which we can't be ignoring, considering its landmark figure of 19.4 months. Next slide, please. And if we have to look between what happens in microscope, in lens, and we see that which subgroup benefited, you could see that every subgroup benefited. So whether it's a male, female, whatever was the age, what was the performance status, subgroup of the smoking or non-smokers. One thing I would like to say was, irrespective of what was the exon 19 deletion or it was the L858R mutation, both of them had a very significant benefit, and that's why we have highlighted this point, and I would like to reinforce doubly, because none of the other trials in their subgroup, we have to remember that the patients were stratified based on their exon EGFR mutation status, whether they were exon 19 deletion, L858R, and then they were given treatment based on that. So many of these trials haven't used the exon EGFR mutation status as a stratification factor. This trial used that factor, and then it has shown a significant benefit, nearly a 38% reduced risk, specifically in the L858R. So if we look at all the trials, be it the FLORA trials, be it the comitinib trials, none of these trials have gone and shown that L858R is the one which benefits with the addition of the TKI as compared to the second the geftinib or the erlotinib TKI. And here we see the hazard ratio lying a lot away from the unity, and nearly a 38% reduced risk of progression, which means it's a very significant figure which we shouldn't be ignoring for our patients and for our daily routine clinical practice. So next slide, please. And if we look at the subgroups also by their pre-specified mutation status, the hazard ratio of 0.62 in the exon 21 and hazard ratio of 0.65 in the exon 19 deletion, meaning more than a 30% reduced risk of progression. So that means that this combination is definitely a very potent combination, even though the relay wasn't power for the subgroup analysis. But yes, it should be very important that there is a very significant difference. So the control arm, if you look at the L858R, performs at only 11 months. If we look at the other trials also, which we shouldn't be doing it, but then again, we can't be restricting ourselves, because it is a common judgment that we should be giving the best foot forward for all our patients. And that's why the exon L858R puts up a very strong case for the combination for our daily clinical practice. And next slide, please. And if we look at the duration of response, then again, the durable response, you could see those curves separating beautifully between the erlotinib versus the erlotinib plus the Cyramza. So the response was durable, and the duration of response was sustained for a longer time, and 18 months, the hazard ratio again showing a significant difference between the two is a lot to look forward to. Next slide, please. So when we look at what happened post T790, those mutations which have progressed, the Cyramza plus erlotinib as the first line EGFR option significantly improves the median PFS and also supports the subsequent use of targeted therapies at progression. So when we look at the rate of how much was the T790 mutation of 1 month after the progression in relay, the combination had a 43%, while the placebo had a 47%. So all the patients who have a progression on the combination should be tested for the T790 mutation, because there is a very high chance, nearly a 50% chance of you harboring that T790 mutations. And this is similar in the placebo group, and we can give them a very good drug in the second line rather than wasting that drug in the first line and then thinking what to do next for our patients. And when we look at next slide, please, the second PFS, that is the PFS2, and you could look that again, whatever happened beforehand, there was a difference in the PFS. Now in this, you could see that the subsequent therapies also have an impact on the combination which you choose first. And therefore, when you look at the hazard ratio, there is a 31% reduced risk of progression, even if you have progressed on the ramucirumab and the erlotinib combination, and you have been given a second line option, and therefore the response are sustained. And it's not only the first progression that helps, but in the second progression also, there is the durability of the response of the prior therapy that you have given, and therefore I believe I think that the OS is not that much matured, but yes, it will have an impact on overall survival whenever it comes, because the PFS1 is greater, the PFS2 is much greater, and we know that 1+1 is synergism with the combination in the science behind it. So the OS would be somewhere a lot that we would be looking forward to. If we have to look at the safety profile of the drug, so again, if you look in the grade 3 grade 4 side effects were 71% in the combination, with the serious side effects being 30% around, and around 12% leading to the discontinuation of the all study treatments. But the condition where the death occurred, one was because of the hemothorax, and one was because of some influenza encephalitis, which was not related to the study treatment. But since it was an um, uh, study, we can't ignore that side effect. But yes, that uh, uh, incident of the grade 3 grade 4 event wasn't related to the drug, and we have to keep that into mind. And therefore the rates of SAE, if we look at it each in of these arm, it was nearly comparable with 15.4 versus 11.6. Discontinuation rate similar, meaning that we have it. And when we look at the areas where the adverse events are of our special interest, we have to look at, as we know, it's a VEGF inhibitor, it's going to cause some of those bleedings. So we see a lot number in the left hand side, that yes, there is epistaxis, yes, there is GI hemorrhage, yes, there is pulmonary hemorrhage, but all these manifesting into a grade 3 or requiring an hospital admission, we see them in single figures. Hypertension, we have learned how to deal with this drug. We proteinuria, we know we how to deal with this drug. Transaminitis is occurring, but yes, it doesn't manifest into again grade 3 grade 4, and similarly is the ILD. So if I have to summarize, I would say that yes, if we are considering the FLORA trial, if we are considering the Decometab trial, we have to also consider the Cyremza Erlotinib combination, since it improves the median PFS by a very large number, 19.4 months versus 12.4 months, with a significant hazard ratio of 41% reduced risk of progression. There is a consistent durability of benefit, and especially with the L858R mutation, where the rest were down performers, this has outperformed with a median PFS of 19.4 months as compared to the placebo plus the Erlotinib with 38% reduced risk of progression. Again, in exon 19, it is a very good option, 19.6 months, the highest PFS so far, and the safety is consistent with the established profiles of the Cyremza and Erlotinib. We have been dealing with them in the second line in the lung. We have been dealing in the gastric cancer, and we know how to handle this molecule. The T790 mutations is similar in both the cases, so it doesn't alters the rates of the T790 mutations post progression, and therefore we have to do a repeat T790. And I believe putting our best drug in the second line would also lead to a second PFS benefit and an OS benefit down the stream, the best benefit we can give to the patients. So I conclude by saying that relay regimen is a new treatment option for the initial treatment of the EGFR mutated non-small cell lung cancer, and it supports the subsequent use of targeted therapies at disease progression. And I believe this to be a very good option for the future. Thank you. Over to Dr. Hemant sir for listening.
Thank you, Dr. Vikas, for a very crisp and very clear presentation of the relay study and the pivotal study on the basis of which the combination of erlotinib and ramucirumab has been approved for use, first-line use in patients of non-small cell lung cancer who have the EGFR mutation. Now, ladies and gentlemen, the EGFR mutated non-small cell lung cancer segment no longer remains a uniform segment. We are beginning to tailor our treatment to what kind of mutation the patient has in this broad segment also. Patients who have the uncommon mutations, exon 20 mutations, other mutations, they form a different group. They have a different natural history of disease. And the two commonest EGFR mutations, the exon 19 mutation and the exon 21 mutation, combined, they constitute about 90% of all cases. They also, we now know for sure, after analysis of so many first, second, and third generation TKIs, that they behave differently. Exon 21 mutated patients have a worse natural history. They have a significantly poorer progression-free survival, and more needs to be done for them. Even our third generation TKI, osimertinib, in the FLORA study did not cross the 1.5-year PFS mark. And now we have a new combination, the combination of a VEGF inhibitor, ramucirumab, with a first generation TKI, erlotinib, which is producing a PFS of more than 1.5 years in this bad prognostic subset of non-small cell lung cancers with EGFR mutation. So ladies and gentlemen, it is time now to tailor treatment to the patient who has the EGFR mutation, and you may choose to select a regime, a different regime of treatment for the exon 19 mutated patients and the exon 21 mutated patients. And one of the more effective regimes, particularly for the exon 21 mutated patients, is a combination of ramucirumab with a first generation TKI. So with that thought, we'd like to close this symposium. I don't see any questions in the question and answer box, and I'm very happy to hand over the session back to the organizers. And as they say in the airlines parlay, happy to report a before time conclusion of this session. So thank you very much. We really enjoyed this meeting, and I hope you did too. Thank you.
Thank you, sir. Thank you for conducting the symposium so well. And thank you, Dr. Vikas, for such a crisp talk. If there are any burning questions, the house is open for the discussion. I just see the chat box if there are any. So I don't think there are any. So I would like to thank the all the panelists and the chairpersons and the speakers for a wonderful session. And I would also like to thank the sponsors, AstraZeneca, Intas, Biocon, Eli Lilly, BI, Novartis, BMS, Pfizer, and Axiom for their support and making this 3 days of webinar a successful event. Have a happy and safe Holi. Have a good night. Thank you so much.